because your priority is to save lives. It has become our commitment. To deliver the ultimate system. With augmented insight. Because a single image can help you change their future. I am.
Everything begins with a simple dot, a single piece of information. And when you begin to connect the dots, data, experiences, needs, ideas, you start learning. That's what humans usually do. That's what I try to do. I could not exist without you. We are made for each other. You have experience, commitment, judgment. I have an endless memory, and I can think very, very quickly. So, if we work together, we can do great things, wonderful things. We can move deeper, faster, safer. We can take better decisions for your patient's health and well-being, together. Thanks to your knowledge, I can assist you in reading every detail of your ultrasound images better and more thoroughly. That's why in Esaote, AI does not only mean artificial intelligence, but augmented insight.
Hola a todos, muy buenos días, bienvenidos a esta nueva edición del curso de Controversias en Cáncer de Mama, actualización y manejo. Buenos días, Darío, buenos días a todos.
Hola Cari, buenos días a todos. Gracias nuevamente por acompañarnos en esta nueva edición, ya creo que es la cuarta, ¿no, Cari? Del curso de Controversias de Cáncer de Mama. Así que bueno, muchas gracias a todos por nuevamente un sábado acompañarnos.
Bueno, vamos a ir contando un poquito a los que se vayan sumando cómo va a ser. La mayoría de las conferencias van a ser en inglés. Para lo cual hay dos canales, uno que va a estar totalmente en español con la traducción en simultáneo, y esto lo pueden buscar abajo en la barra del Zoom, en donde van a ver un mapita y pueden poner que el canal, quienes quieran escucharlo en español, lo eligen en español, y quienes quieran escucharlo directamente en la conferencia en inglés, lo pueden hacer desde el canal que dice inglés. ¿Alguna otra acotación, Darío, con respecto al instructivo para la utilización del Zoom?
No, exactamente. Pueden cambiar en cualquier momento que ustedes están escuchando, pasarlo de inglés a español y viceversa. Como dijo Cari, la mayor parte de las conferencias van a estar dadas en inglés, pero van a tener la traducción simultánea ya de nuestras traductores, que también nos están acompañando, creo, hace muchos años, tanto al inglés como al español, en caso que la conferencia sea en español.
Bueno, vamos a presentar a quien es el director del curso, es el director de la unidad de mama del Instituto Europeo de Oncología, específicamente de la división de cirugía, el profesor doctor Paolo Veronesi.
Y los directores también del curso que acompañan a la Academia de Veronesi es el doctor Gabriel Farante, el doctor Antonio Frazón y el doctor Alberto Rancati. Todos van a participar del curso y van a ser presentados más exhaustivamente a medida que den su presentación. Y nosotros vamos a moderar un poco y presentar las conferencias junto con la doctora Karina Pesce de Argentina, que es la jefa de sección del diagnóstico mamario del Hospital Italiano de Buenos Aires, Argentina, entre muchos otros logros que tiene Cari hoy en día.
Y me va a acompañar en la presentación de las conferencias el doctor Darío Sheckman, que es argentino, pero en este momento está viviendo en Israel. Es miembro del Servicio de Imagenología Mamaria del Hospital de Beilinson en Tikvah, en Israel, y es el director médico de Preventus en Argentina, dentro de tantos otros reconocimientos académicos que tiene Darío, y ambos somos directores de la Comunidad Latinoamericana de Imagenología Mamaria, CLIM. Estos van a ser los conferencistas, Darío, que nos van a ir acompañando, y vamos a ir leyendo cada uno de sus currículum a lo largo de cada uno de estos días y sus presentaciones.
Exactamente, nos sentimos honrados realmente que nos acompañen y que den, sobre todo para el público latino, una iniciativa de la Academia de Veronesi. Y bueno, gracias como siempre a Gabriel, que se esfuerza para que esto siga estando año tras año y llegue a todos ustedes.
Exactamente, para nosotros es un honor que el Instituto Europeo de Oncología nos haya permitido por cuarta vez consecutiva presentar estas conferencias, que al ser gratuita tienen la posibilidad de llegar a toda Latinoamérica. Y queremos invitarlos a quienes todavía no lo hayan hecho a sumarse a nuestra página web, que es Comunidad Latinoamericana de Imagenólogos Mamarios. CLIM, tenemos páginas en Instagram y en Facebook, en donde vamos comunicando cada uno de los eventos, tanto online como presencial, que vamos realizando. ¿Y qué fechas tienen que ir agendando, Darío?
Tienen que agendar la fecha para los próximos cursos. Va a haber un curso online gratuito de CLIM que va a iniciar el 29 de marzo por 4 sábados a las 10 de la mañana. Ya le vamos a ir dando más detalles a lo largo del tiempo, pero bueno, muchos nos preguntaron cuándo empieza. Y el curso presencial, Cari, ¿cuándo va a ser?
El curso presencial va a ser el cuarto curso presencial que vamos a hacerlo en Buenos Aires, teórico-práctico de la comunidad latinoamericana. Todavía no están abiertas, diría, las inscripciones, ni para el online ni para el presencial, pero sí es importante que vayan reservando y organizando las fechas porque muchos tienen que viajar para estar en el presencial. Una nueva oportunidad para encontrarnos todos aquellos que somos referentes y que nos dedicamos a las imágenes mamarias de toda Latinoamérica, en donde podemos compartir nuestras experiencias, con muchas sorpresas para este 2025, que estamos trabajando arduamente en ello, pero vamos a ir develando y vamos a ir comunicando a través de nuestras redes sociales. No se preocupen, que van a recibir mail y avisos en nuestras redes de cuándo comienzan las inscripciones.
Hoy vamos a sortear y tenemos
Hoy
varias
no, vamos a
sorpresas.
sortearlo el último sábado.
Próximo sábado. El próximo sábado vamos a sortear, tenemos varias sorpresas. Vamos a sortear primero 2 libros, 2 ebook del libro de Cari. Para el que todavía no lo haya leído, les digo que es espectacular. Es Signos en Imágenes Mamarias, una guía práctica para radiólogos y no radiólogos. Realmente una forma bien fácil de acercarse a las imágenes mamarias, abarcando todas las formas de imagenología, tanto la mamografía, la ecografía, la resonancia. Cari, ¿dónde pueden comprar el que quiere? ¿Cómo hace para poder comprar el ebook?
El ebook está a la venta por la página web, que es www.doctoracarinapesce.com.ar, y bueno, vamos a sortear para aquellos médicos que participen y se quieran inscribir. Ahí en el chat van a dejar el link para inscribirse en la última jornada del próximo sábado, para quienes hayan participado tanto este sábado durante toda la jornada y el sábado próximo. Y no solamente vamos a sortear este libro, sino también vamos a hacer el sorteo de 2 libros. O sea, en realidad es un libro en español y otro libro en inglés, con el mismo contenido, del Instituto Europeo de Oncología, con la misma premisa, Darío. Tienen que estar conectados este sábado y el sábado próximo, y al final vamos a hacer, cuando ya estemos en el cierre, y tiene que estar en el momento del sorteo los acreedores y los ganadores de este ebook. Ahí Ethel seguramente ya les debe haber compartido en el chat el link para que puedan inscribirse.
Perfecto. Así que bueno, tenemos sorteos de varios libros, tanto los de Karina como los del doctor Pablo Veronese, el doctor Gabriel Faranti y el doctor Roberto Orecchia. Manejo el cáncer de mama 2024-2026. Ya, Cari, estamos superando los 550 inscriptos. Vamos a darle la palabra ahora a la presentación del doctor Gabriel Farante, que es uno de los directores de la Humberto Veronese Academy y forma parte de la división de Breast Surgery del Instituto Europeo de Oncología de Milán, Italia, y es director de la Humberto Veronese Academy de Milán, Italia. Realmente, Gabriel, nuevamente muchísimas gracias. Sé el esfuerzo que te significa poder llegar con todo este alto, ¿no? Porque realmente tenemos la suerte de poder escuchar durante estos 2 sábados a los que están hoy en día en la cima, ¿no? De todo lo que es la patología mamaria. Así que, Gabriel, muchas gracias y gracias por presentar formalmente el curso.
Perfecto. Muy buenos días a todos. Por 5º año consecutivo volvemos a encontrarnos para participar en este curso de actualización sobre el manejo de cáncer de mama, con la presencia y el aporte de profesionales e instituciones de prestigio internacional en esta área clínica, científica, para subrayar conceptos ya consolidados y presentar nuevas propuestas que ayuden a encontrar soluciones teóricas y prácticas para nuestros pacientes con cáncer de mama. Durante estos 2 sábados consecutivos, la Humberto Veronese Academy, UVAC, con el apoyo determinante de algunos de los principales médicos que forman parte del programa de enología del Instituto Europeo de Oncología de Milán, programa dirigido por el profesor Paolo Veronesi, quien el sábado próximo nos presentará una síntesis del voluminoso trabajo que realizamos día a día los miembros de dicho programa. La consistencia de este curso se basa sobre la convergencia de 3 pilares que lo sustentan. El primero son algunas de las principales instituciones líderes en el mundo en cáncer de mama, a partir de los 2 gigantes norteamericanos, el Memorial Sloan Kettering Cancer Center de New York y el MD Anderson de Houston, así como la Mayo Clinic de Rochester, la University of California San Diego y la Columbia University. Europa, representada por el Instituto Europeo de Oncología de Milán, creado por Umberto Veronesi en 1994, justamente este año celebra sus primeros 30 años de existencia y es sin duda uno de los puntos científicos de referencia, sobre todo en Europa. En segundo lugar, el segundo pilar, la convergencia de expertos y científicos más destacados en el sector en sus respectivas especialidades, justamente provenientes de las instituciones antes mencionadas. En tercer lugar, el tratamiento de temas y conceptos más avanzados, algunos de ellos hasta hace muy poco casi inexistente en los programas de eventos científicos más importantes, como los biomarcadores diagnósticos, la cryoablación en cáncer de mama, la fluorescencia en oncoplástica y la protonterapia y otros relacionados con nuevos fármacos o estrategias de prevención. En síntesis, 14 expertos para 14 temas de vanguardia y actualización. Para finalizar, quiero subrayar 2 aportes de contenidos científicos que UBAC, Umberto Veronesi Academy, da a conocer durante este evento. El primero de ellos es el ya nombrado, que es la segunda edición del libro Manejo de cáncer de mama. Se trata de una contribución del programa de senología del IEO, es decir, un compendio y una síntesis del voluminoso trabajo que realiza dicho programa, que es la convergencia multidisciplinaria de todas las especialidades que tratan el cáncer de mama, desde el diagnóstico a la cirugía, desde la radioterapia a la oncología médica, desde la investigación de base a la genética y a la prevención. Este sintético libro es la radiografía de la producción clínica del IEO sobre cáncer de mama. En segundo lugar, el segundo aporte científico que sugerimos es la presentación de un voluminoso libro, Improving Clinical Communication, escrito por uno de nuestros más cercanos colaboradores, el profesor Ernesto Gil de Esa. Este es un libro sobre comunicación médica, es decir, entre lo que aprendemos en la universidad y la práctica clínica diaria existe un vacío en cuanto a la comunicación con los pacientes y sus familias que muchos profesionales de la salud quieren llenar. El objetivo de este libro es cerrar la brecha entre la formación de grado y posgrado universitario y los problemas de comunicación durante la práctica clínica diaria. Consideramos que nunca es tarde para adquirir o mejorar nuestras habilidades comunicativas. Este trabajo será un recurso útil y valioso para cualquier profesional de la salud interesado en el tema. Deseo a todos ustedes el mejor aprovechamiento integral de este curso, que es nuestro aporte para toda la comunidad científica, en particular para los enólogos y mastólogos latinoamericanos. Muchas gracias.
Gracias, Gabriel. Muchísimas gracias nuevamente. Seguro va a ser un gran aporte para todos la comunidad científica, como vos decís, latinoamericana, y creo que se están conectando de varias otras partes del mundo. Creo, Cari, si te parece, y Gabriel también, si estás de acuerdo, que ya podemos empezar, siendo y cuarto en punto, con la primera conferencia.
Por supuesto, Darío, ya estamos en tiempo.
Ok, bueno, la primera conferencia la va a dar el doctor Christopher Comstock del MDA, o sea, y la que va a moderar la conferencia va a ser la doctora Karina Pesce. El doctor Christopher Comstock es radiólogo, forma parte del Departamento de Radiología de Well Connect Medicine de New York, Y realmente muchísimas gracias. Thank you very much for stay here and for give us a lecture. Y la doctora Karina Pesce, ya la conocen, ella le va a hacer las preguntas. El doctor Christopher Comstock va a hablar sobre resonancia y ya creo que puede compartir su conferencia, doctor.
So thank you again for inviting me, and it's always a pleasure to be involved in this wonderful conference. I guess I'm starting off the show here, and from a radiology perspective, I'm going to be talking about the role of breast MRI in the pre-surgical workup of patients with breast cancer. This has been a controversial topic over the last, 20 plus years, and I'll try to touch on some of the aspects of how MRI can improve patient outcomes. So let's talk a little bit about the role of MRI. What are some of the aspects of MRI that can improve outcomes? Number one is extent of disease, determining whether the breast cancer is multifocal, multicentric, if there's contralateral disease, and also if there's nodal involvement or extra-axillary involvement or adjacent structures that would affect the management of the patient. And then there's some aspects of preoperative MRI that people forget about, and that's the new techniques that involve aspects of radiomics and predictive information on the MRI, and also the de-escalation of therapy that can be allowed by the use of MRI and the information that it provides. So, there's been a debate about, getting a preoperative MRI. And I would ask the question, would a surgeon do surgery without a mammogram on a patient first? And if not, then why not use a more sensitive test? And, the premise of having a mammogram is number one is extent of disease and allowing surgery to excise all of the cancer. And so, why is there a pushback against a test that's actually the most sensitive test in determining the extent of disease? So here's a classic example of a mammogram with an obvious cancer. If this had just been biopsied under ultrasound and removed at surgery, there's a high likelihood that this additional high-grade DCIS would have been missed and either missed or obtained positive margins at the time of surgery. So this is an example where obviously a mammogram was important in this patient's management. So MRI is important in that it can determine extent of disease, the tumor size, additional sites. It's more accurate in determining the extent, the measurements, and also whether there's multifocal disease, multicentric, some of the structures involved, and also if there's evidence of metastatic disease. We know that MRI compared to mammography and ultrasound is more accurate in determining the actual measurement of the tumor. Several different papers have shown that the MRI is the best at determining the true size of involvement of disease. And also involved in determining the stage of the patient in terms of nodal involvement and distant metastases. So why is, and so I'll start with really why is there a debate over doing a preoperative MRI in all patients with breast cancer? And in 2003, so almost, a little over 20 years ago, I went to do a fellowship at Akron, which is the American College of Radiology Imaging Network, to learn how to do multi-center trials. I've run a couple of different trials, one on abbreviated MR. I'm currently doing one on contrast mammography. And to do this fellowship, you had to bring a concept or a kind of a working a trial that you wanted to do. And at that time, I wanted to do a preoperative MR trial. And the two heads of the ACR Imaging Network program, Mitch Schnall and Bruce Hillman, They thought it was a valid study that I was proposing, but they were concerned that, and this is in 2003, that by the time I was able to launch the trial, which was looking at preoperative MRI, randomizing patients to either a pre-op MR or no pre-op MR, they were concerned that I'd have difficulty in doing this study because preoperative MR would become the standard by the time I started the study. And so it's ironic that still to this day, 20 years ago, there is no standard. In the United States, you can go from one medical center to another medical center, and some, use a lot of preoperative MR, and some do very little. So I'm going to try to get to the heart of the matter and try to focus on, how you could select patients where preoperative MR may be most beneficial, and where patients maybe, it's not necessary. So where is the debate? Well, the debate becomes that there have been quite a few studies showing, particularly if we look all the way back to Dr. Holland's data in 1985, where there were patients who were thought to have localized breast cancer, and then they had mastectomies, and he looked through those mastectomies and found that there was, in 43% of patients, there was disease greater than 2 centimeters from the site of the primary index tumor. So we've known for many years that there's quite a bit of additional disease. And, MRI really is just a tool that can now see that extra disease. But so what are the implications? There's also been from Husseini et al., who published in 2008, a meta-analysis showing that when you do a preoperative MRI, you find additional disease in about 16%. So quite a few patients will have additional disease. And that does change surgical management in a fair number of patients. But the debate becomes that the extra disease, so detected in some cases in 1 out of 6 patients, how does that change their outcomes by finding or imaging this extra disease? And the debate is that, number one, the MRI can, add cost, delays, and time for the patient to have surgery. We know that the recurrence rates are already relatively 5-year recurrence rates are, 2 to 5%. So the question here is, although we have a tool now that's more sensitive and can see additional disease, the debate is that, that extra disease is being treated by radiation therapy because we don't see a 16% or more, recurrence rate. So the concern is that we're finding disease that really isn't affecting outcomes because it's being treated by radiation therapy. But I will add the caveat that there are patients who do recur, and there are patients that die from breast cancer. So, where can MRI help improve management? The question is, does this additional disease that we detect on MRI, does it affect outcomes or mortality? Right now, obviously, we don't have any outcomes or mortality data because that's very difficult to study in these types of patients. So how can we make preoperative MRI more acceptable in the patient workflow and patient management? Well, number one is to lower the cost, reduce scheduling delays. And you generally see in the United States centers that do a lot of preoperative MRI. The radiologists work closely with the surgeons. So they communicate the results. They're not at a lot of unnecessary biopsies, and it really helps tailor the surgery for the surgeon. One aspect is targeting patients who have the potential for advanced or metastatic disease, or patients who have a higher likelihood of recurrence. And those are more aggressive tumors, tumors in younger patients, and all right. Sorry, I'm just forwarding my slides here. One question is, now I'm not sure if people are familiar with in the United States, there's a fair amount of centers that are offering something called abbreviated breast MRI, where that's used more for breast cancer screening. It's a shortened protocol. Generally, sometimes it's just a pre-post contrast, and sometimes it includes a T2 weighted series. But for a preoperative MR, I think it's important that patients undergo a full MRI. And some of the important series for that type of MRI include, what's important is a pre-contrast T1 weighted non-fat suppressed sequence, which allows you to see, fat planes and also evaluate lymph nodes a little better than if you did not have a non-fat suppressed image. Also, some information that can help in radiomics, diffusion weighted imaging, and obviously the pre and post contrast series. So I think it's important if you're doing preoperative MR that you do a more of a full series in order to have enough information to help accuracy. So who could you target? I wouldn't suggest the need for preoperative MR in a 76-year-old patient with a fat density breast with a 7 millimeter cluster of calcifications. I think there's not a lot of indication that the MRI is going to add that much in terms of management. But there are patients, obviously, at a lot of centers I worked at. Number one, a patient who's young in their 40s or younger. A lot of those patients are getting preoperative MR, patients with invasive lobular cancer, patients with family history or genetic mutations are getting preoperative MR because those are the patients who have a higher risk of additional disease and contralateral disease. So as I mentioned, situations to consider preoperative MR would include women with dense breast, younger women, invasive lobular, primary cancer that's not evaluated well. And this is where on mammography and ultrasound, and this is where the radiologist can communicate with the surgeons. There are cases where, a radiologist interpreting the mammogram and ultrasound, they get a sense of, this is a difficult tumor in a particular patient to evaluate extent because the margins aren't well seen. And so if there's good communication, there's patients where the radiologists feel like, the MRI may be helpful in really defining the extent. So there's obviously, extended disease may convert some patients who were felt to have localized disease or focal breast cancer, who have much more extensive disease. The MRI can allow them to proceed with a mastectomy rather than going through 1 or 2 or 3 lumpectomies that keep getting positive margins. And here's a case where the patient has a palpable tumor in the axillary tail of the left breast. It looks like it's at least multifocal. There's several masses there, but the MRI shows that this is much more extensive, all the way towards the near the nipple. And so in this particular situation, we would not, we never recommend a mastectomy based on the imaging or the MRI. We would recommend sampling for histologic confirmation of the anterior extent. And then once that biopsy is proven to show, much more extensive disease, then the appropriate management of the patient would be a mastectomy. Now, one controversial aspect of preoperative MR is, can the information on MRI be used to help the surgeon obtain clear margins? And that's the difficult aspect. And I don't think really there have been any studies that have shown this with statistical significance, and that's because when the patient has an MRI, they're supine. They're prone in the magnet, but when they have surgery, they're supine, and so there's a big change in the breast position, and it's really hard if the surgeon doesn't have the 3-dimensional images from the MRI imaging. Obviously just a report is not going to help them visualize and try to improve the excision. Here's an example of a patient who was felt to have localized disease And then with the MRI, we see that, see if this will play, we see that there's, in addition to the primary tumor, there's several satellite lesions throughout that quadrant. And in this particular case, MR-guided biopsy was performed of the more medial aspect, and that allowed bracketing of this area, and surgical clear margins were obtained on the first attempt at surgery. Now, we know if this patient had just proceeded to surgery, there's a high likelihood they would have had positive margins, or they would have had clear margins, and they would have missed several areas of cancer, which would put them at a higher risk of recurrence. So this is a case where the MRI really helped manage the patient. Here was, and so that's an example of multifocal disease where MRI was able to improve the margins. But there have been quite a few studies. I'm still working on publishing the Akron 6694 study we did with the American College of Surgeons, ACOSOG, which is now called the United States. We're working on publishing our data from a study 10 years ago where we randomized patients to preoperative MR looking at margin rates. But I can just tell you, looking at the data from that study, I don't really think we improve margin rates all that much. And you can see there have been various papers, not very few being statistically significant, which show that the margin rate either in some cases was improved and in some cases was not improved and was not as good. So I think that's important to really communicate with the surgeons, the information, have the surgeons have the ability to look at the images, look at the 3D information in order to help them visualize the extent of the tumor. Now we're going to move on from extent of disease to additional information where the MRI is more useful. It's better than ultrasound. It's better than mammography. And that's at evaluating contralateral disease, nodal involvement, additional structures that are involved, such as the chest wall. We know that MRI detects in about 4% of patients additional disease, about 1/3 DCIS, 1/3 invasive cancer. And most of that disease is early stage node negative disease. So several studies, this was a meta-analysis of 22 studies. The most notable one in the United States was Connie Lehman's Akron study. But, it's about a 4% contralateral detection rate. Now, I don't have time really in this talk to talk about contrast enhanced. I believe my wife, Janice Sung, next weekend will be talking about contrast enhanced mammography. But I think it's an area that's promising. We've done a couple of studies on contrast mammography. That's when I was at Sloan Kettering, showing that for extent of disease and also for response to tumor residual disease after neoadjuvant therapy, that contrast enhanced mammography is actually pretty close to MRI. And, the importance of that is MRI is access is limited. It's most centers have difficulty getting time on patients scheduled for MRI versus contrast mammography. Most modern mammographic units can be upgraded to do contrast mammography. So I think something to think about if you don't have access to MRI and you want the benefits. But again, it's good at extended disease and contralateral disease. The MRI can see beyond the breast that can be included on a mammogram. So there are benefits of an MRI, but something to think about if you have the availability of contrast mammography and you don't have the availability of MRI. This was just early work showing that contrast mammography had kind of a similar detection rate to preoperative MRI. This was Maxine Jockelsen's data, which showed that the contrast mammogram was similar for the index lesion, although the MRI was able to find a little bit more sensitive for additional disease. But the MRI did have more false positives than the contrast mammogram. So here's an example of a contrast mammogram. comparing to MR. Here's the mammogram, which shows just a dense pattern. Here's the MRI showing extensive disease. And here's the contrast mammogram showing a very similar pattern. So something to consider in countries or cities where you don't have MRI available. So let's continue on the benefits of MRI in terms of extra disease outside the breast. And one is obviously evaluation of lymph nodes. Most of our patients, unless the MRI or ultrasound or mammogram show, more than 3, very suspicious lymph nodes, most patients in the United States, because of the Z11 trial, will proceed with just a regular sentinel node biopsy. But there's cases where the MRI shows more extensive adenopathy, and those patients would get biopsied and then may proceed to more full axillary dissection rather than a sentinel node. So features to look at for the lymph nodes are obviously the most suspicious is loss of the fatty hilum, eccentric cortical thickening, but MRI only has about a 65% sensitivity for metastatic lymph nodes. So just because the nodes look normal on the MRI, the patients would still need to proceed with a sentinel node biopsy for their management. Here's an example of how the non-fat suppressed pre-contrast image can allow you to see fat and aspects. This is an abnormal level 1 node. And so when we evaluate lymph nodes on preoperative MR, we evaluate based on the pectoralis minor. So lateral to pectoralis minor here is level 1 nodes. Posterior to the pectoralis minor, these would be level 2 nodes. And then when we see nodes more medial to the pectoralis minor, those would be categorized as axillary level 3 nodes. And so that information can help the surgeon know the extent of adenopathy and for their axillary dissection. Obviously, mammography won't include lymph nodes. Here's a case of the mammogram with a patient with breast cancer, and we see this extensive, large metastatic lymph node that's not visualized on the mammogram. So in addition to axillary nodes, we can see internal mammary nodes, Rotter's nodes, and supraclavicular nodes. Here's an example of a patient. Particularly, you want to be suspicious when you have a large tumor that's medial in the breast. You have to be careful for metastatic internal mammary nodes. Here's a grossly abnormal node. Now, I will tell you that we do see lymph nodes, normal internal mammary lymph nodes, in about, 15, 20% of patients if you just did a scan on patients. Those generally are small, 2, 3, 4 millimeters, flat, oval. Once you start getting over 5 millimeters in a patient with breast cancer, it's kind of a presumptive diagnosis that you need to be concerned that there's internal mammary node involvement. And this may affect radiation therapy planning. Here's a patient with a PET scan, and we can see a big a tumor, and then we see an internal mammary node that's active. Here's another example of a sagittal MRI showing this extensive tumor in the inferior right breast, and then we see this abnormal internal mammary node. Generally, we don't biopsy. If we see something like this, we put this in the report, and we say that it's a presumptive diagnosis. It's pretty suspicious for an internal mammary node involvement. Occasionally, we biopsy these patients. It can be done under ultrasound. Obviously, it's a little bit tricky with the chest, the lung, and the heart and the aorta right in the vicinity. So you need to be fairly careful when you do these. But those can be done if it's needed to be done. This was a case of a patient who had recurrence. And so the reason this was biopsied because she had had a prior lumpectomy and breast cancer, and they wanted to know that this tumor was the same biology as the regular cancer. So this was important in planning their treatment. So we know that the pectoralis muscle, if just the pectoralis is involved, it doesn't really change the staging of the patient, but it may affect the surgery. The surgeon, if they know that some of the muscles involved, will have to take more of the muscle. Now, if the chest wall's involved, that would change tumor because that's considered distant metastasis rather than, the muscles rather than just the pectoralis muscle. And it will affect skin-sparing mastectomy, if the skin's involved or if the nipple's involved. So the MRI can add information in planning these types of, skin-sparing mastectomies, et cetera. Here's an example of a tumor that abuts the chest wall. But there's a little bit of obliteration of the fat plane, but there's no real infiltrative enhancement or involvement of the muscle. So this shows that there's no chest wall involvement, versus in this case, we see that there's quite a bit of infiltrative enhancement into the muscle, and there's also skin involvement here. There's a contralateral tumor here. So the pectoralis is really considered part of the breast. So involvement of that doesn't necessarily change the stage, but if there's an invasion of the chest wall, the serratus, intercostal muscles, that would upstage the patient to a T4 category. And so we've talked about the information, doing preoperative MR can help define extent. Hopefully, if it's done well and communicated well, it can improve the margin rates and likelihood of getting clear margins on the first surgery. It can help determine if a patient's not a candidate for conserving therapy and needs a mastectomy. It can evaluate lymph nodes, et cetera. Now, there's information on MRI that, these are new aspects of MRI. And one of them is that the information that we see on an MRI may be helpful in predicting outcomes and planning therapy. So it's a whole new field in MRI, and that involves radiomics, or the information that we see. We know that there's all sorts of information that the radiologist, patterns that the radiologist may not be able to really comprehend or see, whereas a computer analyzing, thousands of data points may be able to see with the use of AI. We know that just from MRI, when we see tumors, there's a vast variety of presentations. And so the fact that there's all sorts of presentations and types of tumors seen on MRI implies that there's likely a biological difference in these patterns that the MRI may be able to help link to the genetic profiling of the tumor and also planning the appropriate therapy. Whereas we know that solitary tumors tend to respond better to treatment versus multifocal type of tumors or diffuse tumors. And so there are certain aspects that the MRI can help predict whether the therapy is going to work or not. Other information, diffusion-weighted imaging is something that can also be used to be predictive of the type of tumor and the response the response that is predicted. Another aspect that the MRI looks at is the microenvironment of the tumor, and this one aspect is peritumoral edema, and patients who have higher peritumoral edema or reaction to that tumor have a much worse prognosis because of that. So this is the aspect that we call multiparametric information. We have the morphologic shape, the pattern of the disease in the breast. We have the kinetics. We have the intra and peritumoral radiomics, or the environment of the tumor, and then we have diffusion-weighted imaging. So this information paired with the genetic profiling, either some centers do the Oncotype scores and Oncotype DCS scores. That information combined with the radiology or radiomic information is a promising new pathway to evaluate appropriate therapy and likelihood of response. So I've always been, we do preoperative MR, and we do a lot of we do imaging or MRI after neoadjuvant therapy, and we look for response to tumor. And the number one response is obviously shrinkage or reduction in the volume of the tumor. But I've always been a believer that there's information already there before the treatment that probably is just as robust as predicting the response. So I think there's a lot of promising work. So we may not have to do the treatment and then monitor and then see if the therapy works. I think together with the information from the genetic profiling, the MRI, we may be able to predict that up front rather than having the patient go through therapy that does not work. And so there have been various papers. I won't spend any time on this, but there have been papers showing that this multivariate approach can be predictive in patients with certain tumors, particularly triple negative and HER2 positive tumors. And so lastly, I'll finish with, there's another aspect of preoperative MR, and that's de-escalation of therapy. And there have been several studies that have been worked on, and that is the combination, particularly in patients with DCIS. Can they avoid radiation therapy? But radiation therapy is several weeks of radiation therapy. It's expensive, $20,000-$30,000 in the United States. Can we use MRI and genetic profiling like the Oncotype DCIS score to predict patients who have a low risk of recurrence and avoid radiation therapy? And so why those two tests? Why the MRI and why the genetic profiling? Well, the MRI can look at burden of disease, and patients who have a much higher extent or volume of disease that wasn't predicted on mammography and ultrasound have a higher likelihood, even if the biology is not aggressive, that they have a higher chance of recurrence because there's so much unsuspected disease and that radiation therapy can't overcome all that extra disease. Versus the tumor biology, the tumor markers can define, patients who have maybe not extensive disease, but very aggressive. And those patients need radiation therapy. So I think there's a belief that the combination of the MRI and the genetic profiling can calculate based on both tumor burden and tumor biology. So there've been a couple of studies that I've worked on with ECOG Akron, and one is follow up to the Taylor X study, which is looking at patients who first, have thought to have localized disease. They're planning breast conserving therapy, lumpectomy. They get an MRI to see that they don't have more extensive disease. And then after the MRI, they get an Oncotype score. And for patients with a low score who can still have a lumpectomy, about 30% of patients could avoid radiation therapy and have a less than or 2% or less risk of 5-year recurrence. So I think those are promising studies. There's a couple of different studies in the works looking at that. So I think there's a lot more information. So I'm going to just summarize here. MRI is our most sensitive tool, but in order to use it effectively, there has to be a high communication between the surgeons and the radiologist. You need to select patients who it's most useful for. I don't advocate doing preoperative MR on every patient, but there's clearly patients who, particularly younger patients and aggressive tumors, where it's useful. And so in addition to the extent of disease and lymph node involvement and staging, there's also the radiomics component where I think the information may, in the near future, be useful in predicting the appropriate therapies for patient along with genetic profiling. So I think MRI is continuing, and now that the cost and access is coming, down and access in countries is becoming more available, I think it's being done more and more for preoperative MR. I don't think it's the standard anywhere yet, but I think, most programs, if they have experience and they work with the surgeons, can use preoperative MR successfully. So I think we'll see more and more MR being used. And again, I mentioned contrast mammography, which is an option for some centers, mostly for extended disease, not so much for extra mammary involvement, lymph nodes, or radiomic information. So thank you very much, and appreciate inviting me to this conference. Thank you.
Excelente, doctor Christopher. Felicitaciones por su brillante presentación. Quiero hacerle dos preguntas. La primera pregunta, usted habló de inteligencia artificial en la evaluación de las imágenes con resonancia. En su práctica diaria, ¿cuál es el software que utiliza? Y si esto usted ha visto y ha medido las métricas, si le ha mejorado las tasas de verdadero valor positivo para las biopsias y ha disminuido la tasa de falsos positivos.
So one of the in the question and answer is about doing supine MRI. Actually, I know of one company that's looking at doing MRI in the supine position, just so that it helps. The information is more transferable to when the patient's in the operating room. The problem with supine is on the MRI, the breast is then kind of compressed. So I think it's a challenge. I don't think that's going to become standard anytime soon, but there are companies looking at that. So I think it's interesting work. There's a question about MRI and ultrasound correlation. It says the hospital doesn't have MRI guided biopsy. They need to do it under ultrasound. The problem is if you could find everything that was seen on MRI with ultrasound, we wouldn't need MRI. Clearly, there's going to be a percentage of lesions that you just can't see on ultrasound. So, one comment I would make, if you don't have MRI biopsy, it's really important to try to get MRI biopsy for those, because you're not going to be able to find them all and you're going to be missing lesions. Some centers who don't have enough time on their MRI to do biopsies have been doing contrast mammography biopsies on their MRI findings. So that's, if you have fairly modern mammographic units, those can be upgraded to do contrast enhanced biopsy, but something to think about. But you need to have either yourself the ability to do contrast or MRI biopsy, or you need to have a partner, some center that you can send the patients to if you don't see them on ultrasound, because you're only going to detect, 40% maybe on second look ultrasound. Let me see here. So is MRI more sensitive than ultrasound for lymph nodes? I think generally if we have I think it's more sensitive, the MRI is, because, the ultrasound, once you get, it's not as good deeper into the axilla. So I think it's more sensitive in terms of finding all the involved lymph nodes potentially. But I think ultrasound's a little more specific, because once you do have a node you're evaluating, the features on ultrasound really are kind of the decision point in whether or not to biopsy, and if it looks abnormal, loss of the fatty hilum, cortical thickening. So I think that, you need both really, if you really want full extent and the best sensitivity and specificity.
Christopher.
So, yep.
The last question, if you want to answer, because we need to move to the next.
Okay.
But if you want to finish that.
Here's a good one. How much does contrast enhanced MRI cost at your hospital? Well, if it's not covered by insurance, it could be almost, $4,000 to $5,000. It's very expensive. But most of the time it's covered. Insurance only pays about anywhere from $500 to $1,500. The government, the Medicare pays. So it all depends on insurance. But I think that's where the cost of MRI is coming down now that they're making lower cost MRI units. And I think I'm just going to end here. I think that there was a $22 million award to Yale University, John Lewin, looking at low-cost, low-field breast MRI. And I think in the next 10 or 15 years, the model will change where breast centers don't have to rely on the radiology department to share time on the magnet. The model will change that breast centers will have MRI units like they have mammography and ultrasound units. So I think that's going to change in the future, and the cost will come down a lot. So thank you very much.
Okay, thank you, Christopher. Thank you very much for staying with us. And we need to continue. And Cari, if you want, si querés presentar al próximo orador. And thank you very much, Christopher, really.
Seguimos con la segunda conferencia, que es la del profesor doctor Virgilio Sacchini. Va a presentar el moderador Francisco Pimentel sobre la siguiente tema.
And thank you for this invitation. For me, it's always a special honor to be present in this incredible course. And I'm presenting today the state of the art of the breast surgery here at Memorial Sloan Kettering, and also some studies that we have in progress. And of course, the most important topics is the escalation of breast surgery. That is not something new, but it was started by the master, the teacher of most of us, Professor Veronesi in Milan. And I'm proud to be here in this academic Professor Veronesi course. And the escalation is going on in surgery, and the escalation is mainly due to the possible other integrated treatment that we have now. And sometimes the escalation in surgery means escalation of chemotherapy, radiation therapy, immunotherapy. But how we can go far to the escalation? Yes, we can avoid in some case, in case of exceptional responders, the surgery in some cases. And the reason is that we can predict the response to the chemotherapy. This is a study that we did here at Memorial Sloan Kettering on predicting the response through MRI core biopsy with a very high positive predictive value of 100%, specificity of 100%. And there is a very interesting study now in progress, also based on some preliminary result of the MD Anderson study. The study is in progress in Milan in cooperation with Memorial, in which in exceptional responders, MRI, mammography, ultrasound negative, we do core biopsy under ultrasound, and in cases negative, we only do radiation therapy, sample size 77 patients, accrual in 2 years, multicentric study. But not only we have at disposition other treatments, more and more treatments, target treatments to decrease the breast surgery, but also we can better predict how the other treatments may work on the cancer. And of course, in luminal cancer, the prediction is done by genomics. We use here at Memorial the oncotype. There are many, MammaPrint, that can predict the treatment. And this is a very interesting study on neoadjuvant chemotherapy and correlate with the oncotype score with high prediction of response when the oncotype score is very high. And this is something that we apply already at Memorial Sloan Kettering in patients with positive lymph nodes to the site in luminal cancer to do chemo from neoadjuvant chemo or surgery. And on core biopsy, we do genomics, and if the oncotype is high, more than 25, we do the neoadjuvant chemotherapy on these patients. When it's low, we do surgery, and of course someone can discuss about the neoadjuvant hormonal therapy that we are not doing in these cases. In premenopausal patients, of course, it's still controversial. We have the data of the responder in which there is a benefit in N plus premenopausal patients in giving chemotherapy anyway, and even if the oncotype score is low. And of course, the discussion is if these results of the responder are due to the induction of the menopause in patients who had chemotherapy. The other arm, hormonal therapy, didn't have the ovarian suppression. So this is something still open, but here in the States, in premenopausal with positive lymph nodes, we still do neoadjuvant chemotherapy up front. But the prediction, the score can also be useful in predicting the local relapse if the patient didn't have radiation therapy. And this is a very interesting study correlating OncoScore to the relapse in case of not radiation. And if the OncoScore is low, less than 10, the risk is very limited of local relapses. And this is the first results of the IDEA study. And Memorial is a participate center in which with the less oncotype score luminal cancers, of course, less than 2 centimeters, we were not doing radiation therapy with very, very good similar results at 5 years follow-up in the 2 group with or without radiation therapy. In the, of course, last 10 years, even more concentration was done in trying to avoid the axillary dissection, to avoid the lymphedema. That is still something important in breast surgery. I would say that is the most important element reducing the quality of life of our patients. With mastectomy, we can do better reconstruction, and nipple-sparing mastectomy, improving a lot the quality of life. But if we need to dissect the axilla, we have risk of lymphedema, especially if we do radiation therapy. And this is a very interesting study done by our group on more than 300 patients. And you can see that the risk of lymphedema at 24 months was quite high, 23.8%. Interesting to know the ethnicity play a role in this risk, and also the neoadjuvant chemotherapy, especially patients who had capecitabine after. Probably the capecitabine can create reaction, more fibrosis after the surgery, increasing the risk of lymphedema. How is the axillary policy at Memorial Sloan Kettering regarding the axilla, the axillary surgery? Of course, we try to avoid the sentinel lymph node in clinically negative N0 patients, and we are trying to avoid the axillary dissection in N1 patients. How? Of course, everyone knows the concept of choosing wisely. Society of Surgical Oncology, American College of Surgeons, in which more than 17 luminal cancers, of course, there is no benefit in removing the lymph nodes. We don't have any additional information regarding the treatment. And even no radiation, accordingly to the CALB 9343 trial, increased risk, a little increased risk of local recurrences without impacting the quality of life. Of course, we pay extremely attention in balancing the risk and benefit of the treatment in these patients, especially regarding the comorbidities. Can we avoid the sentinel node in less than 70 years old patients? And we have the excellent sound trial, randomized multicenter trial, showing no difference in patients with sentinel lymph node staging or ultrasound negative staging without impacting the disease-free survival and the overall survival. A large sample size, 1,405 women randomized to have the sentinel lymph node staging versus the ultrasound staging. Of course, in case of suspicious ultrasound, fine needle aspiration proving cancer in the lymph node, the patient had the axillary dissection, and again, no difference in the adjuvant treatment, and this was the most important thing. So the two staging didn't affect the adjuvant radiation, the possible adjuvant radiation, the possible chemotherapy or hormonal therapy. But there is a caveat, of course, because the study was done before some interesting data regarding the CDK inhibitors, the Monarchy study, the Natalie studies, in which in some high-risk patients, additional CDK inhibitors were given to decrease the risk. For instance, this is the Monarchy study with the abemaciclib. And in some high risk, and there is a cohort 1 in which the high risk patients were defined as more than 4 lymph nodes, and in the cohort 2 patients, 1 or 3 positive lymph nodes, high Ki67, there was a benefit regarding the treatment with the CDK inhibitors. The benefit was important, and the reason why there was an approval by the Food and Drug Administration of the abemaciclib in these patients, almost in all the world now. But if we analyze a little better the patients in this study, there were 2 cohorts, the cohort 1 and the cohort 2, and the cohort 2, 1-3 lymph nodes with high Ki67 was quite minimal. The most was the cohort 1. So we can assume that the most benefit was done in more than 4 lymph nodes positive patients. But if we compare the sound population with the Monarchy population, you can see that the real patients entering the similarity in the cohort 1 more than 4 positive lymph nodes. Unfortunately, the sound study cannot provide the cohort 2 similarities patients. Let's say in the most part of the Monarchy patients with the benefit for the CDK inhibitors, the number in the group of sound patients were about 0.6%. You may say it's very small, but when you treat like Memorial about 4,000 breast cancers, this number may be quite important if you can give a benefit. This is the reason why we decide to apply the sound criteria with some limitations by now. By now, of course, there are studies in progress, especially the use of the CDK inhibitors now based on the primary, independently on the lymph nodes. But by now, what we wanted is to decrease the possibility to have patients that can benefit from the CDK inhibitor. So our criteria of selection was more than 50 years old, postmenopausal, ER-PR positive, of course, nominal cancer, and G1, G2, not including the G3 patients, stage T1, and we are still performing the sentinel lymph node biopsy when the ultrasound is abnormal, of course, when the cancer is multicentric, or when the cancer is more than 3 centimeters at the final pathology, or G3. The other topic is, can we avoid axillary dissection in some N1 patients when at the presentation the patient has an axillary metastasis? And of course, the answer is, of course, in triple negative HER2 positive patients, yes, but what about then N1 with possibly low oncotype score? Of course, we can do accordingly to the Z11 study. So when at the final pathology we have the less than 3 lymph nodes, we apply the Z11 criteria. What about the mastectomy? The Z11 was only for conservation surgery, and there is this very nice study done by Corrado Tinteri in Milan, showing that in the Synodar study, only done in mastectomy when the patient had less than 3 lymph nodes and didn't have the axillary dissection, the prognosis was the same as the patient had the axillary dissection. Limitation of the study, follow-up not extremely long, and the number that is more than 200. So we are still thinking and deciding to apply this criteria in the mastectomy patients. The Z11 trial was quite a straightforward, pragmatic trial, clinical examination without any ultrasound in the axilla and image. But what about now in this context when all the patients have an axillary ultrasound and possibly fine needle aspiration? We need to do the axillary dissection, or we can still apply the Z11 criteria because the patient is anyway N0 at the physical examination, like the Z11 population. We analyzed our data, we published, and we saw that when the cytology was positive at the end of the story, in 59-60% of patients in which the ultrasound showed only one suspicious node, the patient had only one node, so entering the Z11 criteria, avoiding the axillary dissection. But if you, excellent radiology would tell you, look, there are more than one lymph nodes, where still in 33% of the patients, we have less than 3 lymph nodes, and the sentinel lymph node can be apply entering the Z11 criteria. So what we are doing now in patients with positive cytology, but N0, the clinical examination, we still do the sentinel lymph node biopsy. And of course, if the patient has more than 3 lymph nodes, we need to do the axillary dissection. But what about the clinically T1, T2, N1 patients, when you fill the lymph node, so the patient doesn't enter the Z11 criteria because it's N1. We are speaking, of course, about the luminal cancers, luminal A. We decide to do this study. Of course, it's a protocol in which we still are doing the sentinel lymph node biopsy. and see the final pathology or do frozen section during the surgery. So the protocol is CT1, T2, N1, clinically N1, and luminal cancers. And what to do? We do the mapping, and we remove the sentinel lymph node. Of course, is N1, so it is easy to remove the involved lymph node. And then if at the final pathology or during the frozen section, the patient has less than 3 lymph nodes, we avoid the axillary dissection, entering the patient in a sort of Z11 criteria. When, of course, there are more than 3 lymph nodes, we do the axillary dissection. But this is the the preliminary results that will be presented at San Antonio this year. And you can see that at the end of the story, when you apply this criteria, when you do this type of surgery, sentinel lymph node, T2, T1, and 1, in about 68% of the patients, they had less than 3 lymph nodes entering the so-called Z11 criteria, and we were able to avoid the axillary dissection in more than 32% in more than 3 lymph nodes. In 32%, we do the axillary dissection. Of course, is a study in progress with the consent of the patient. But what about the other patients in which we do neoadjuvant chemotherapy? Of course, we know the sentinel lymph node can be done, very good specificity. And the open question is, do we need to clip to localize the affected lymph node after and remove that lymph node after the neoadjuvant chemotherapy? And if you look at the data, I would say yes, because you can have a decrease of the false negative result from 10% to 1.4%. This is the well-known study from the Anderson Cancer Center. So clipping the node is, of course, of benefit regarding the statistics. You have an important decrease in the false negative rate. But at the end of the discussion, is useful, can really reduce your risk of relapse, and the partial answer was done by the Oncoplastic Breast Consortium study. This is a multi-center study, more than 1,100 patients, in which the data collected, retrospective study, of course, around the world, in which they did the so-called target axillary dissection, in which they removed the lymph node that was affected, versus other centers in which they didn't remove they removed probably, but they didn't do the localization of the affected study. Well, the study show same results in terms of local recurrences. Of course, the follow-up is not so long, but 3 years may be fine without any difference in terms of the two methods. And the other I would say arguments in favor are the studies, especially the Milan study, the one with the long follow-up, in which they didn't clip the positive node, they didn't localize the positive node, the mean lymph node that they removed was 1.5, showing a very low risk of local recurrences, 1.6% after 10 years, the longest one, confirming some other smaller and shorter follow-up studies in which it seems that the target versus the conventional mapping doesn't change the risk of local recurrences. This is the policy that we use at Memorial Sloan Kettering, in which we don't clip the node, we don't do pre-operative localization, dual mapping, blue and radioactive, removal of at least 3 lymph nodes. If the lymph node was clipped before by another institution, we don't localize it, and is not required to remove these lymph nodes. Changing a little the subject, is the axillary dissection always required when the lymph node is positive after the chemo? And the answer is yes, but there are 2 important studies in which radiation therapy is done anyway after the axillary dissection, or the patient is randomized not to axillary dissection, and is the Alliance in United States and the Taxis in Europe. We don't have yet the results, but what about the minimal diseases like immunopositive cells? And again, the Oncoplastic Breast Consortium did a very interesting survey and statistical analysis on patients who had or not the axillary dissection, 694 patients with no difference in the risk of local recurrences. But what about the micro metastasis less than 2 millimeters? Again, study by the same group. The data will be presented this year at San Antonio, 1,200 patients, and follow up 3 years without any difference in the local recurrences with or with an overall survival, with or without axillary dissection. We are doing, in case of axillary dissection, the lymphovascular anastomosis, and I would say that can really decrease the risk of lymphedema at 24 follow-up. And I would like to conclude that the escalation is important, was shown by important clinical trials, but patients entering the clinical trials are very motivated. They sign the consent, they do what you tell them, taking the pills, everything. But what about in the normal world? You can see that even in Sweden, that is a country in which the health system is very developed. Patients, for instance, taking the aromatase inhibitors, in 25%, they may not take the aromatase inhibitors because they have side effects. So the adherence of the treatment may be low. And what does it mean? It means increase the risk for this patient. This is a study that we did in which in patients more than 70, in which we didn't do the radiation therapy, there was an increased risk of local recurrences if the patient didn't take the aromatase inhibitors. For this reason, we are a study in progress here at the Memorial, in which in this patient, more than 70, we try to see if the patient can deal with the hormonal treatment, and we give the patient 6 months of neoadjuvant hormonal treatment, aromatase inhibitors, and then we decide if the patient is able to tolerate this treatment, we do surgery and avoid the radiation. If not, we do the conventional treatment. Thank you so much for your attention, and I'm available for any questions.
Thank you very much, Virgilio. Thank you very much. And Dr. Francisco Pimentel, you can make 1 or 2 questions because we don't have for the honor of the time. Thank you.
Thank you. Good morning, guys. I'd like to thank the organizers for the invitation. It's a truly honor to be here with friends and professors. Dr. Sacchini, congratulations on your beautiful presentation. 2 quick questions for you. The first one, recently the FDA approved ribociclib in patients with early breast cancer and any disease, just 1 lymph node for indication. So how do you imagine the omission of sentinel lymph node biopsy in postmenopausal patients in this case? And the second one, what's the protocol now for memorial slow catering after the NSABP 51 trial, and your recommendations in radiation therapy? Thank you very much.
Thank you. Thank you, Francisco. And of course, we are thinking to extend our criteria after the Food and Drug Administration approval, even in N0 patients. So it will be the next step of our action. Second, of course, the B51 was a very good surprise, and we are de-escalating more and more our criteria for the radiation. The problem of this trial is that all patients had an important pre-op screening with CT, at least CT, not showing an internal mammary lymph node. So, of course, the pre-op staging is very important in these patients to be able to avoid the escalation of radiation in order to have the same criteria as we had in the P51.
Okay. Thank you both. Thank you, Dr. Sacchini. Thank you, Dr. Pimentel. And Karina, if you want, si querés, continuamos con el programa. Thank you very much.
Thank you.
Continuamos con la siguiente conferencista, que es la doctora Mónica Huang. Ella es profesora asociada del Departamento de Imágenes del MD Anderson en Houston, y va a ser moderada las preguntas por el doctor Gastón Rey. Dejo de compartir para que la doctora pueda...
So I will be speaking on breast cryoablation, talking about all the de-escalation of breast surgery. This is actually one of the most probably attractive options for non-surgical treatment of breast cancer currently that has been quite popular. These are my disclosures. So I will be talking about the clinical indications for breast cryoablation in the United States and our breast cryoablation program here at Anderson. I will very quickly talk about the patient selection, imaging, preparation, technique, post-ablation, follow-up, as well as the future of ablation in breast cancer treatment. So in the United States, we actually have 2 clinical indications for cryoablation for the breast. If number 1 is the fibroadenoma, that actually went into effect earlier than the one for breast cancer. These are indications that have a billable code so that we can actually perform these procedures clinically. For breast cancer cryoablation, it is a temporary code, and that means that it's still basically being evaluated to see if it is feasible to keep based on all the data that it's been accumulating over the years. At Anderson, we perform cryoablation for 2 purposes. for curative as well as palliative intent. Certainly for curative, we're talking about there is no other cancer foci in the body, and we really want to, once we treat the breast, the patient will be considered cured. But for palliative purposes, we are also performing cryoablation to ablate the index tumor, although the patient may have other metastatic foci in the body. We may completely ablate it or partially ablate it so that we can actually add adjuvant therapy to it or for symptom relief. So I will go over some of our cases that we have done in our study. So in Anderson, for tumors that are ultrasound visible, less than 2 centimeter lymph node, we would always use ultrasound to evaluate the lymph node is lymphonegative. We can then offer patient curative cryoablation, and all others, patients who are poor surgical candidates but don't fit this criteria or have failed standard of care therapy, cannot tolerate standard of care therapy, or decline standard of care therapy, we also may offer them breast cryoablation. However, this is always done together with a multidisciplinary team. Basically, the breast imaging department cryoablation program does not accept patients unless they have been evaluated by our MD Anderson multidisciplinary breast oncology team. So I wanted to go over some of the data that we have for palliative breast cryoablation because actually this is what first started cryoablation. This was performed for palliative intent for those patients who have either primary advanced recurrent breast cancer that have failed standard of care treatment, and it was demonstrating to improve survival, certainly symptom relief or resolution of pain. And incidentally, it was noticed that, hey, when we treated the breast recurrent disease, or really early on, it was really at the mastectomy site at the chest wall, we noticed that there's regression of contralateral breast tumor and lymph node metastasis, not only the reduction of the tumor itself in the breast that was treated. And certainly the complication rate was very, very low, and this was well tolerated. And therefore, this happened starting in the 1960s and continued even currently. And really in the early 2000s, the curative intent breast cancer cryoablation work began. And work began to show that, hey, in these small number of patients, there is promise, and that we can build perhaps a framework for future research. So the first multi-center prospective trial was the ECOSOG Z1072 trial, in which actually MD Anderson participated. This was basically treatment of breast cancer with cryoablation followed by surgical excision within 28 days of the cryoablation. The tissue was then evaluated for any signs of residual cancer. And if you excluded multifocal disease outside of the ablation target, it was proven to be 92% successful ablation and 100% successful if the target was less than 1 centimeter. And this was published in 2016. This was followed by more recently the publication by Find et al. Of their 3-year interim analysis results for their large-scale multi-center trial. Again, this was activated in 2014, and this was done in patients, in women 60 years or older that had ultrasound visible, unifocal invasive ductal carcinoma, 1.5 centimeter and smaller, so a little bit smaller than the Z1072 patient population. And also in comparison, the Z1072 patient population included other invasive cancers and not just invasive ductal. And these, at least in the I3 trial, were low to intermediate grade, ER/PR positive and HER2 negative, what was considered to be low risk. Definitely no lobular carcinoma or any extensive DCIS, and actually Z1072 included some lobular carcinoma. This was clinically lymph node negative, and they did not do surgical excision after cryoablation. This was only followed with imaging. And basically at 3 years, they published their interim results demonstrating that the ipsilateral breast tumor recurrence rate was very low at approximately 2%. They accrued 194 patients versus in Z1072, we had about 87 patients that qualified for analysis at the end of the trial. So our program, which is a clinical program, began really in 2021. We have performed over 140 breast cryoablation consultations, have treated over 45 patients now and over 60 lesions. This includes fibroadenomas as well as cancer. And we recently published early on this year, while we had at the time, of course, we have more patients now that was not included in the study, that show that we performed this procedure for the curative as well as palliative intent and was overall successful in almost 97% of the patients. Now, of course, our median follow-up was only 16 months. And this was actually performed on unifocal as well as multicentric tumors, ranging for the curative intent, of course, under 2 centimeters, but really for the palliative intent up to about 6 centimeters. And we were trying to help also define how do you define success for not only curative, but palliative treatment in breast cryoablation. For our patient population, the standard reasons for referral are very similar to others. Most of the time, these are referred by our surgical team or oncology team because the patients have medical comorbidities and they were at very high risk for surgery. Some decline surgery. This is for the curative arm. And actually for the palliative arm, similar reasons for referral, but a lot more decline of, standard of care. But some of it really had to do with our patient's age. The median age for our population for breast cryoablation is about 77. So a lot of patients much more elderly, not only medical comorbidities, but there were quality of life concerns and considerations, which basically made them decline either the chemotherapy or surgery. So we basically split the two groups into the palliative as well as the curative. And really anybody who did not qualify for curative, meaning the tumors were bigger than 2 centimeters, or they had any metastatic disease or had previous surgery already, or neoadjuvant chemotherapy, we did not include them in our curative group. We looked at both, not only the procedure objective, meaning was the tumor successfully ablated, but also we had some specific patient treatment objectives. So for the procedure objective for curative, we certainly do not want to have any residual recurring carcinoma at the ablation site. For the palliative, we actually we have patients that we were just simply trying to reduce the tumor volume. So it wasn't really, some of them really, we were not aiming for complete ablation. And I'll explain a little bit. For example, we had a patient that had a 1.5 centimeter invasive cancer, but her DCIS was about 6 centimeters. She was basically offered mastectomy. Her breast size was very small. She declined, and therefore we ablated the invasive cancer, so did not ablate the entire DCIS. That was not possible. She then received radiotherapy and chemotherapy afterwards to control her disease. So these are some of the more complex cases that we have seen. So for the curative, certainly very simple. We do not, again, we're looking for no residual recurrent carcinoma in the treated breast on imaging. But for the palliative, we have other patient treatment options, objectives, I should say. So some of it was for relief of pain. Some of it was basically we wanted to control the growth of the tumor so it did not invade into the cancer. It does not then erode through the skin, cause any other clinical problems. So, we kind of were very specific and spoke with the patient specifically about what the purpose of our treatment is, and to be sure that we can actually meet it and meet patients as well as the oncologist's expectations. So, patient selection, really preparations very much the same as breast biopsies, no restriction in medications. And we attempt to always have imaging that included some sort of contrast study within 3 months. We always image with mammography as well as ultrasound the entire breast as well as node basins to evaluate not only the lymph nodes but potential for multifocal, multicentric disease. Not all our patients received MRI or CEM, but we certainly aim to try to do that because certainly without the benefit of surgery and surgical margin evaluation, we are unable to evaluate the margin if we don't have good imaging prior. However, most of our patients were elderly and some of them could not even tolerate the MRI. Many of them did not get a contrast study prior to that. But this helped us to basically look at the approach, select appropriate cryo probe. On the market, there are cryo probes utilizing argon as well as nitrogen. The argon needles are much smaller in caliber, and there are MR compatible argon cryo probes, while the nitrogen cryo probes are a little bit larger in caliber. But certainly I use multiple cryo probes when necessary, depending on the size of the tumor. The nitrogen cryo probes, I believe you can only use single cryo probes, however. So this is kind of our testing for the procedure, our procedure tray. I'm not going to go more into it, but you can read more in our paper. There are 4 mechanisms for tumor destruction, certainly direct cellular injury, indirect injury to the vessels causing ischemia, apoptosis of the injured cells, which causes delayed DNA program cell death, as well as some of the immunomodulation effects, such as the abscopal effect that really people are trying to explore and enhance in conjunction with the utilization of immunotherapy. So basically, when we are cryoing a tumor, ice basically forms not only inside the tumor, but outside of the tumor. And when that is preferentially actually is outside of the tumor with, basically withdrawing water from these cells and dehydrating it. And when it thaws, that's when the water re-enters the cell and membrane rupture occurs, basically sending antigens of the tumor into the body and systemically activating the T cell. Now, injured cells then can undergo cell death. It's not immediate. And thereafter, and also compared to other forms of ablation, such as the heat-based ablation, radiotherapy included, cryoablation actually induces greater post-ablation immune response. And this is what many are trying to enhance: the T cell activation, the abscopal effect, the destruction of the tumor cells, not only in the tumor, but also in lymph nodes and distant metastases with the use of immunotherapeutic agents. So this is kind of our classic example how we perform cryoablation, utilizing ultrasound as guidance, putting the cryo probe within the tumor and extending beyond it to be sure that we actually ablate not only the tumor as well as surrounding margin. We also perform MRI guided. As you can see, this is actually utilizing multiple cryo probes, and that is possible with the argon. We perform, of course, follow-up thereafter with clinical as well as imaging follow-up 2 to 6 months. And why 2 to 6? It all depends. Now, if our patients are also receiving adjuvant therapy, we then try to coordinate with that. Now, why is it important to image early on? Early on is really when you basically are unsure, or really this is the best time to look at the effect of your ablation. For example, this is a patient in her 90s, poor surgical candidate, we are trying to ablate this, and you can see that basically the patient's skin and bones, skin, very little tissue tumor, and this is her muscle. So when we were ablating it, we couldn't ablate it completely. She was complaining of a lot of rib cage pain for the ice ball, touching the rib cage. So we actually had to terminate. So we brought her back at 3 months to see the effects of ablation. And actually, interesting enough, partial ablations result in lack of fat necrosis and in basically inflammation around it in the normal tissue. Actually, we have seen this with partial ablations where the tumor just disappears. And you can see that at 12 months, again, the tumor remains gone. Now, in patients who have more aggressive tumors, we do perform cryoablation on high grade, as well as triple negative tumors sometimes when necessary. This is a patient, a very poor surgical candidate. Actually, before the diagnosis of breast cancer, she was on the transplant list. So on the day of cryoablation, we noted that actually the tumor had almost doubled in size from when we first saw her 3 months prior. So we knew that this is fast growing. We saw a lot of this echogenic rim around it. We were concerned that there is some tumor invasion into the tissue and it's more bigger than this 2 centimeter. So we decided to use 2 cryoprobes to be sure that we can create. And of course, we brought her back. This is a modification of our standard protocol, which is in that publication I showed you earlier. But we brought her back, but this is the best time to see whether or not we actually achieve this sufficient margin. This is the best time to see the effects of the cryoablation imaging. This is what happens though after cryoablation. You can see the inflammation. Eventually it starts to contract and calcify. And this will be the best time that really we need MRI or contrast study to see, to follow these. So we do add this, but we always use mammography as well as ultrasound because there are some benefits to that. So you can see that the area of fat necrosis treatment change is contracting. We can see that under ultrasound. We always look for the clip. This is a patient, as you can see on mammo. This is pre-cryoablation. 6 months after, we don't see much. There is some density, but can we really tell that there is no tumor? We add the ultrasound. This is what pre-cryoablation, the tumor looked like. 6 months, we see the post-cryoablation change, and here's the clip and no tumor. 12 months looks pretty good, but where's the clip? So we're very diligent about finding the clip. So we finally found the clip, but so do we, find also the additional recurrence. We noted that she actually had multiple. We biopsied both, and they were micropapillary pattern of growth, DCIS, as well as invasive ductal. This patient did not have a contrast-enhanced study prior to cryoablation. We believe that probably she had a background micropapillary DCIS, and no matter what, we cryoablate there with a background, more cancer is going to pop up. So it would be very important to get that MRI or even CEM, if possible, prior to cryoablation. Now, this is a patient that we cryoablated, multicentric disease. This is after cryoablation of 2 tumors, and we saw this humongous area of inflammation. But we were like, is this cancer? Is this progression? And then we performed the MR to show that indeed this almost looks like a surgical cavity. There is no residual tumor there. Now, this is once we got the ability of CEM. We followed this patient 6 months post-cryoablation. We we now have CEM. Let's do it because she could not tolerate MR. And then we noticed, although we treated this area looks great, it was a new cancer, or was it there before? And we assumed that it was probably there before since this was only 6 months post-cryoablation. And you can see that it is mammographically as well as sonographically occult. We eventually treated that as well. So we talked about the T cell activation, how we have immunotherapy that tries to enhance that, but really suppressing the T cell suppression so that we can continue to prolong this T cell activation and basically destroy tumors outside of the breast, in the lymph nodes, as well as metastatic foci. So there's hope that combined with immune checkpoint blockade and we enhance the sustained response to tumor-specific antigens, that this will actually improve breast cancer therapy response compared to other standard of care or either treatment alone. So I wanted to show you a case of ours in the same multicentric patient. She had 5 tumors in the breast that was treated every 3 to 6 months. I told her jokingly that it's almost like getting a vaccine booster to her immune system. And her metastatic disease, she had metastatic disease to axillary levels 1 and 2. Actually was stable for 20 months since we began the cryoablation. Actually, before that, within 9 months, she had progressed from axillary level 1 to axillary level 2 disease. And so for 20 months, her axillary lymphadenopathy was stable. We believe that that may have some thing to do with her abscopal effect of our cryoablation, the multiple ones. More importantly, cryoablation offers patients some benefits in quality of life. This patient, although in her 90s, was extremely very active, lived by herself, very independent, and she was able to maintain her normal, active lifestyle without any side effects and complications. Anyway, thank you so much for your attention, inviting me to this wonderful conference.
Bueno, muchas gracias, doctora Mónica Huang. Tengo en realidad 2 preguntas. ¿Se me escucha?
Sí.
Sí. Tengo 2 preguntas.
I can hear. Puedo escuchar.
Una de índole clínica y una educativa. La clínica es si cree usted necesario en los tumores triples negativos, que sabemos que incrementan la concentración de CD8 y son muy inmunogénicos, necesaria o estándar el tratamiento crioinmunoterápico, tanto como para fines curativos como paliativos, más allá del estadio del paciente, para aumentar el efecto auscopal.
Now, I know that there are trials, but not currently at MD Anderson for that. So I cannot speak to our breast medical oncology experience as to after what I do, whether or not they add immunotherapy. Basically, we always have a team, and if they elect to, they may do so, whatever chemotherapeutic agent or immunotherapy, they may add to it if they feel that it is beneficial and is appropriate. I kind of leave that decision to our breast medical oncologist, since I don't right now have a protocol for that.
Muy bien. Y la otra pregunta, más de índole educativa, es ¿cómo es la curva de aprendizaje para este método y cómo son los modelos de entrenamiento? ¿Son siempre in vivo o utilizan otros modelos?
No, we don't use other models, but we actually, all the breast imaging radiologists, we do a lot of breast interventions. One of the benefits for the breast imaging radiologists to perform this procedure is that, as you know, for breast cancer, not all breast cancer is like a fibroadenoma where I show, or that triple negative breast cancer tend to be more circumscribed. And therefore, you have to recognize, for example, in my patients, when I saw that there is that echogenic halo around the tumor, maybe people may not recognize that who are not breast imagers. They may just see that oval circumscribed tumor. But we also have a lot of tumors we treat very irregular in shape, very indistinct margins, very hard to tell where it ends and begins. And really, it's necessary not only to be able to place the CryoPro appropriately in that tumor, but to select the appropriate CryoPro. For example, I use the argon cryoprobes. I have multiple available options. I can use multiple also CryoPros at the same time. So the learning curve, depending on where you are and what your goal is. Let's say, for example, you are going to only cryoablate 1.5 and smaller. That's what I would recommend you start with. If you're starting a service in your institution, is begin with, like, For example, very easy one, a fibroadenoma, one that you can see very well, make sure that you can actually put the cryo probe in the tumor and not really approach a very ill-defined tumor beginning. So what we did, since we are very, we do procedures all the time, so we don't have any issues with the ultrasound or MR guided procedures, but really just the utilization of the cryo probe. So luckily, our interventional radiology department performs cryoablation of other organs, the lung, the liver, the kidneys, the bone. So we go observe as to, how the machines use. And actually, we then collaborated with them. We performed the procedure in their suite with their supporting staff, because you have to have supporting staff that can run the machines as well. So those are really all the considerations when you are kind of starting a service, not only the training for the radiologist or surgeon, we have breast surgeons do it, we have interventional radiologists doing it, but also your staff support.
Thank you very much, Monica. We continue with the next speaker. The next speaker will be Dr. Kelly Hunt, del MD, y el moderador va a ser el doctor Antonio Frazón. La doctora Kelly Hunt is chair of the Department of Breast Surgery del Oncology MD Anderson Cancer Center. Dr. Kelly Hunt, if you want to share your presentation, please.
Wonderful. So I'm going to be talking about neoadjuvant endocrine therapy in early stage breast cancer. So first, I'll talk a little bit about the scope of the problem with respect to hormone receptor positive breast cancer, the rationale for using neoadjuvant endocrine therapy and how we select patients, treatment duration and evaluation of response, and then finally a little bit about new targets in the treatment of endocrine therapy resistant breast cancer. So as we all know, we now speak about breast cancer subtypes from the gene expression profiling into the luminal subtypes, luminal A, luminal B, the HER2 enriched, and the basal subtype, which is also the triple receptor negative. In practice, many of us use immunohistochemistry to define these subtypes instead of the gene expression profiling, and we typically refer to these as approximated subtypes because we know they're not always the same as those defined by gene expression profiling. In terms of breast cancer incidence, when we look at this by subtypes, by far the most common is the hormone receptor positive HER2 negative subtype. And then this is true in all different races as compared with triple receptor negative, hormone receptor positive HER2 enriched, and hormone receptor negative HER2 enriched. We know that about 50% of all breast cancer patients in the US are at least 65 years of age. It's most commonly diagnosed after age 60. And tamoxifen has been one of the drugs that's used in hormone receptor positive breast cancer patients and has been shown to be twice as effective as chemotherapy in preventing relapse and death from ER positive breast cancer in postmenopausal women. Now, over the last few decades, we've had a lot of studies, clinical trials looking at other agents such as aromatase inhibitors, and they've been proven to be more effective and safer than tamoxifen in postmenopausal women, whereas we typically still use tamoxifen in premenopausal women. So our typical approach has been to do surgery first. Surgery first, and then use adjuvant agents such as chemotherapy and endocrine therapy, depending on the findings from surgery. But over the last few decades, we've started seeing the neoadjuvant approach utilized more often for different subtypes, especially the HER2 positive, HER2 enriched, and the triple receptor negative subtypes, where we give systemic therapy first, we assess response, and then do local regional therapy after the neoadjuvant systemic therapy. When we use neoadjuvant therapy as compared to adjuvant therapy, we know there is no survival difference, whether the agents are given before or after surgery, but it does decrease the rate of mastectomies, decreases the incidence of nodal metastasis, and we know that outcomes are associated with response, specifically pathologic complete response is associated with improved survival rates. And we also have the residual cancer burden index, which is associated with long-term outcomes as well. So what about neoadjuvant therapy in hormone receptor positive breast cancer? Well, this is from the NSABP studies. This was published many years ago showing that when you compare tamoxifen and chemotherapy, that the value of chemotherapy in ER-positive breast cancer is age-dependent. So as with increasing age, there's less impact of the chemotherapy and more impact of the endocrine therapy. And when we look at subtypes of breast cancer and the pathologic complete response rates, this is from a review several years ago showing that the hormone receptor positive subtypes has the lowest pathologic complete response rates with neoadjuvant chemotherapy. And that's whether you define it as PCR in the breast and the axilla or PCR in the breast only. The lowest rates are seen in the hormone receptor positive breast cancers. So what about neoadjuvant endocrine therapy? This has been studied by several investigators, especially in older women. This is a trial that was comparing neoadjuvant endocrine therapy to neoadjuvant chemotherapy in over 300 postmenopausal women and looking at the pathologic complete response rates. What this phase 3 trial showed was that there was no difference in PCR rates, whether the patients received chemotherapy or endocrine therapy. The rates of breast-conserving surgery were slightly higher with the endocrine therapy, although not statistically significant. And the endocrine treatment, of course, was better tolerated than the chemotherapy. Well, now we have things like the 21-gene recurrence score assay, which helps us to predict chemotherapy benefit in hormone receptor positive breast cancer. We have data from the TAILOR-RX trial that showed endocrine therapy alone is sufficient when the recurrence score is between 0 and 10 in node-negative breast cancer. There's some chemotherapy benefit in premenopausal women when the recurrence score is over 16, but no benefit for postmenopausal women when the recurrence score is 11 to 25. And in the RxPONDER trial, these were women who had 1 to 3 positive lymph nodes, and there was no significant chemotherapy benefit in postmenopausal women when the recurrence score was less than 25. So this is a patient who was treated with letrozole, one of the aromatase inhibitors, for 3 months. And what you can see is just based on mammography, there was a significant response in the breast with only 3 months of endocrine therapy. And when this has been looked at by different investigators, they've shown that the aromatase inhibitors do have a higher response rate when compared with tamoxifen, promoting breast-conserving surgery and potentially an alternative to chemotherapy. And when we started to look at this in the American College of Surgeons Oncology group, at the time there were no direct comparisons between the 3 aromatase inhibitors that are available, and there were no large neoadjuvant endocrine studies that had been conducted in the US. We also weren't sure what were the appropriate endpoints since we know that PCR rates are quite low overall. So we designed the Z1031 trial, which was looking at postmenopausal breast cancer patients that had strongly ER-positive breast cancer based on the all-red score of 6 to 8. They had clinical stage 2 to 3, so larger tumors, and in some cases positive lymph nodes as well. And they were randomized to one of 3 aromatase inhibitors for 16 weeks and then had surgery. The primary endpoint was the clinical response rate, both complete and partial, and then there were a number of secondary endpoints as well. And we looked at postmenopausal by standard criteria, and you can see that we included patients with T2 to T4 disease, any nodal status, but no metastatic breast cancer was included. And we looked at the endpoints for those that had T2 to T3 disease, where we converted from mastectomy to breast conservation, those who had T2 disease, where a lumpectomy at first attempt was the goal, and those who thought had more advanced disease, whom mastectomy with negative margins was the goal. What we found was that in terms of clinical response rate, it was similar across all 3 aromatase inhibitors, and that's something that, of course, we've learned from the larger adjuvant trials with aromatase inhibitors, but you can see that the number of patients needed to evaluate this in the neoadjuvant setting is much lower. In terms of the surgical outcomes, we did find that 82% of patients that were thought to be marginal candidates for breast conservation were able to have breast conservation, and this was judged by the surgeon before treatment was started and then at the time of surgery. And you can see that 50% that were thought to be candidates for mastectomy only were able to have breast conservation, even some that were thought to be inoperable at presentation. When we look at local regional recurrence events, what we see is that there were very few local recurrences or regional recurrences. And when we looked at those patients that did have a local regional recurrence event, we saw some that had lumpectomy, some that had mastectomy, and some that had suppression of Ki-67 below 10% at surgery. The 5-year cumulative incidence rate for local regional recurrence is estimated to be 1.6%. So very safe to downstage patients with endocrine therapy, even with larger tumors. We saw that when you look at all of the 3 aromatase inhibitors, that the change in Ki-67 was similar across all of the aromatase inhibitors. There were some patients who had an increase in Ki-67 from baseline to surgery. And interestingly, when we looked at subtypes by gene expression profiling, we saw that there actually were some HER2 enriched patients, even though we looked at very strongly ER positive tumors that were included in this trial. When we did the gene expression profiling, we found that some were actually luminal B and HER2 enriched. So what about Ki-67 as a marker to tailor endocrine therapy? Does the lack of Ki-67 suppression identify patients who might do better with chemotherapy? That was one of the questions we asked. And then, is there an alternative to PCR that we can use in hormone receptor positive breast cancer? Well, Matthew Ellis and others described what is called the preoperative prognostic index for endocrine therapy, the PEPI score, and you can see with this index, it's tumor size, nodal status, Ki-67 level, and ER status, and it's associated with recurrence-free survival and breast cancer-specific survival. This is from one of the PO24 and POL trials, data showing disease-free survival in patients who had a modified PEPI 0 score. You can see excellent long-term survival, whereas those who had non-zero modified PEPI score had worse outcomes overall. So data from the POL and IMPACT trials show that you could actually use Ki-67 index at 2 to 4 weeks after starting the endocrine therapy, and that this correlates very well with the surgical specimen, which is typically obtained 3 to 4 months later after aromatase inhibitor. So what was used was a cutoff of greater than 10. And when they looked at this, they found that chance of getting PEPI 0 was less than 2%. So if the Ki-67 was greater than 10% after 2 to 4 weeks of endocrine therapy, very few of those patients would get a PEPI 0. And 20% of patients will have a Ki-67 of greater than 10% at 2 to 4 weeks. So we did cohort B for the ACOSOG Z1031 study in order to look at this on-treatment biopsy at 2 to 4 weeks after aromatase inhibitor. And we saw that the patients that had a Ki-67 that was not suppressed would be recommended for chemotherapy. Some went directly to surgery. We planned accrual to screen 200 to 230 patients, and 35 were actually triaged to chemotherapy. So chemotherapy was physician's choice. We recommended that patients be switched if the Ki-67 was greater than 10%, and the predefined efficacy threshold was PCR rate greater than 20%. So we thought that if these patients were strongly hormone receptor positive, but the Ki-67 did not suppress, they might behave more like estrogen receptor negative tumors. But only 2 of 35 patients who switched to chemotherapy experienced a PCR, so still very low PCR rates. And you can see here recurrence-free survival in these patients that had did not have a suppression of Ki-67 in the blue line. They had more breast cancer-related events compared with those who did have suppression of Ki-67. And similar results were seen in the previously published POL trial. So why did this fail? We thought that chemotherapy might be more effective in these patients, but these are mostly postmenopausal patients, which we talked about. Chemotherapy is less effective in that setting. Very ER-rich tumors. They might be poor prognosis despite the use of chemotherapy. And this does underscore that there are some tumors that are intrinsically endocrine therapy resistant. And so when we looked at the PEPI 0 versus non-zero in the Z1031 trial with a median follow-up of 5.5 years, if we look at all patients, you can see PEPI 0 does very well, PEPI non-zero. The patients that did not receive chemotherapy, still PEPI 0 was a good indicator of those patients who did very well. So how do we increase the PEPI 0 rate? What about duration of treatment, alternative endocrine therapies, looking at different pathways or combination therapy strategies? And so this is from a study from Mike Dixon in Scotland, who showed that with increasing duration of therapy, that the tumor volume decreases. And so typically our preoperative or neoadjuvant endocrine therapy trials have been 3 to 4 months of treatment, but you can see here that tumor volume does decrease with longer therapy. And you can see that the PCR rates were found to be increased after 12 months of therapy. What about other tools for patient selection? We've been using immunohistochemistry for the approximated subtype, but what about using tools like the 21 gene recurrence score assay and the MammaPrint or Blueprint assay? This is from a study where they looked at oncotype score, the trans-neo study. So recurrence score less than 18, you can see that there was less than 1% with progressive disease, and most patients actually had either a complete or partial response, or some having stable disease. Now, this is clinical assessment, complete or partial response, clinical assessment, usually by palpation or by imaging. As the recurrence score increases, you can see fewer patients that have complete or partial response. And what about the MammaPrint assay? So this was a trial with that Pat Whitworth published with his colleagues, looking at molecular subtyping, and what they discriminated tumors that were luminal A, B, HER2 positive, and basal subtype using the MammaPrint assay and also Blueprint. Pathologic complete response rates were compared with conventional immunohistochemistry that we use for the approximated subtype. And what they found was that the MammaPrint index was positively associated with the likelihood of PCR. So the higher risk, higher MammaPrint, higher PCR rates. And then if you look at the different subtypes by Blueprint, you can see that the luminal subtype has the lowest PCR rate, as we know, based on the typical immunohistochemistry and approximated subtype. And of course, the basal subtype and HER2 enriched had the higher PCR rates. When they did multivariate logistic regression analysis, they showed that Blueprint, subtype, and grade were significantly associated with the odds of achieving a PCR. And then patients with a true luminal type tumor can be candidates for neoadjuvant endocrine therapy. So there were 53 patients with blueprint luminal tumors that received neoadjuvant endocrine therapy with an aromatase inhibitor, and 68% had a clinical response. So this is another tool that we can use for selecting patients. But what's the appropriate endpoint with these trials? Should we use clinical response rate by palpation, which is what most of them did, radiographic response rate, which is typically mammogram and ultrasound, but perhaps MRI or other things might be better. PCR rates are low in these hormone receptor positive breast cancers, so it's probably not the best endpoint for us to use. Ki-67 seems to be a good endpoint, and PEPI score. So this is from a study published by Mitch Dowsett and his colleagues looking at Ki-67 as a biomarker of response in patients who were treated with only 2 weeks of endocrine therapy. This is the POETIC trial. So they looked at Ki-67 baseline measurement, and you can see here the recurrence-free survival, and then Ki-67 on the surgical specimen after 2 weeks of endocrine therapy. And so you can see that the higher the Ki-67 after just 2 weeks of endocrine therapy correlated with recurrence-free survival. And the Ki-67 and multi-gene proliferation score was looked at in the ACOSOG Z1031 trial. And you can see with increasing multi-gene proliferation score is correlated with pre-treatment Ki-67 and week 2 biopsies. So in this group that suppressed to less than 10%, this group greater than 10% were more associated with a higher multi-gene proliferation score. So what about using alternative endocrine therapies like fulvestrant, which is a selective estrogen receptor degrader? So there have been a couple trials comparing anastrozole with fulvestrant, showing improved outcomes, overall survival in the first study, and improvement in progression-free survival in the Falcon study. So this was the impetus for designing the alternate trial, which was performed by the Alliance for Clinical Trials in Oncology. And in this trial, we looked at neoadjuvant endocrine therapy with anastrozole versus fulvestrant versus the combination. And this was for 6 months of therapy as opposed to the typical 4-month treatment that we've done in other trials. We looked at the modified PEPI score, and for those that were modified PEPI non-zero, they would receive chemotherapy, physician's choice, whereas those who had a PEPI 0 would receive adjuvant therapy in one of these arms listed here. So this was recently published, and we looked at the endocrine-sensitive disease rate, and these were postmenopausal patients with estrogen receptor-rich, HER2-negative breast cancer, and we were trying to see if this endocrine-sensitive disease could be assessed by either PCR or modified PEPI 0 score. We also looked at secondary endpoints like Ki-67 suppression, PCR rate after switching to neoadjuvant chemotherapy, and many correlative studies, including genomic and transcriptomic analyses to understand endocrine therapy resistance. So there were over 1,300 patients that were registered, and you can see the 3 different arms here. And this is the primary endpoint, which is the endocrine sensitive disease rate, which is modified PEPI 0 plus PCR rate. And what you can see is that there was no difference between the 3 arms. So neither fulvestrant containing regimen improved the endocrine sensitive disease rate over anastrozole. We did see that the combination led to a greater 4-week Ki-67 suppression compared with anastrozole alone in the luminal B tumors, but not in the luminal A tumors. So we know that there are many different pathways for endocrine therapy resistance. It's a complicated situation in terms of tumor microenvironment, growth factor receptors. There are secondary messengers, especially the PI3 kinase pathway. EMT, cancer stem cell cycle machinery is now being looked at, and apoptosis and senescence all can be loss of ER expression, can all lead to resistance in terms of endocrine therapy. In ACOSOG Z1031, we did genome sequencing for 50 patients, and we looked at those where the Ki67 remained above 10% after AI and compared this to those where it's suppressed, and we considered that resistant versus sensitive. We compared the whole genome sequencing, and we did find 8 significantly mutated genes that were already known, but 9 significantly mutated genes that were not previously observed in breast cancer samples. So again, that we know that there's crosstalk between ER and the mTOR signaling and the PI3 kinase mTOR pathway. And so people have looked at combining AKT inhibitor with anastrozole. This is a small study of 51 patients led by Cynthia Ma, where they found that 16 of 22 patients with mutations received study drug, but there were no PCRs in this study. What about, I talked about the cell cycle machinery. We've heard a lot about CDK4/6 inhibitors now. And so there was the NEO-PAL-ANA trial, which was looking at a new endpoint called complete cell cycle arrest. So this is defined as the Ki67 less than 2.7% on a cycle 1 day 15 biopsy 2 weeks after anastrozole and palbociclib. And this study showed that there were some patients who achieved complete cell cycle arrest, but comparing the agents, adding palbociclib converted non-cell cycle arrest to complete cell cycle arrest in 60% of patients. The PALET trial also looked at using palbociclib and letrozole in different schemas. Primary outcome was clinical response by ultrasound and change in Ki67. And you can see the change in Ki67 here based on whether the patient received letrozole or letrozole plus palbociclib. So a higher log-fold change in Ki67. The NEO-MONARCH trial is postmenopausal ER-positive breast cancer randomized to a 2-week lead-in of anastrozole versus abemaciclib or anastrozole, abemaciclib followed by 14 weeks of abemaciclib plus anastrozole. And these are some of the results from that study looking at Ki67 suppression with the different agents. And you can see that abemaciclib plus anastrozole performed better than abemaciclib or anastrozole alone. So just to wrap up here, neoadjuvant endocrine therapy trials are feasible with relatively low toxicity. We know from the Z1031 trial and POL trial and others that conversion from mastectomy to breast conservation can be achieved in more than 50% of patients with a clinically meaningful benefit, and underscores the value of using this approach in women who have ER-rich tumors, especially those who desire breast-conserving surgery. Ki67 at 2 to 4 weeks and PEPI score are measures of resistance to AI therapy, endocrine therapy. And biomarker and somatic mutation-based stratification are necessary for rational trial design, and now looking at combination therapies that might improve outcomes for our patients. Just to acknowledge all the individuals involved with many of these studies, and especially our patients who participated in so many of these trials. And this is the Key Hunt lab that I'm fortunate to be a part of, and that is working on this problem in patients with endocrine resistance and those resistant to CDK4/6 inhibitors as well. Thank you very much.
Thank you very much, Doctor. We have time, Dr. Antonio Frazon, for makes 2 questions. You are mute. You can unmute now if you want and make the question for the Dr. Hunt.
Thank you very much for the presentation, Kelly. And thank you for the invitation. It's a pleasure to be here. Kelly, do you believe that we should use in luminal tumor patients something like oncotype or blueprint in the biopsy specimen to decide in a fast way which patient should be candidate for hormone or chemotherapy in the neoadjuvant setting?
Yeah, I think it's been shown now in many different studies that using those tools can be very helpful. And so, of course, we use the Oncotype DX assay in the adjuvant setting all the time to decide about chemotherapy. And so there have been plenty of studies now looking at the difference in recurrence score between the core biopsy and the surgical specimen, showing good concordance between the two. So I think if you get a biopsy, a core biopsy, and you check the recurrence score and it's high, that gives you your answer that that patient is likely going to receive benefit from chemotherapy compared with those that have a low recurrence score. And that's where using neoadjuvant endocrine therapy may help us to achieve breast conserving surgery in more patients.
Okay, Kelly, thank you. That's all. Thank you.
So the subject of my lecture today will be the impact of radiation on breast reconstruction with implants. And these are lessons learned from a three-decade experience. I have no disclosures. There are two parts of this lecture. The first is to discuss the impact of radiation on implant-based breast reconstruction. And I'm going to show you some data looking at outcomes and optimal timing of the reconstruction. And the second part of the lecture will be to share a three-decade experience with radiation and breast reconstruction. And these are mostly insights and observations without data, but with a large clinical experience. So to start out with timing and outcomes, what's the impact of radiation on two-stage implant-based breast reconstruction? We know that post-mastectomy radiation therapy has become increasingly common for patients with advanced breast cancer. My personal approach to implant-based breast reconstruction in patients who receive PMRT has evolved over a two-decade period, and I'll share some of that experience and how things have changed. So how does PMRT impact outcomes in patients with implant-based breast reconstruction? This sort of summarizes my overall experience between 1992 and 2019. I now have probably about over 5,000 breast reconstruction patients. In this group here, you can see about 6,000 were implant reconstructions, about 4,500 were had no radiation. And then in yellow are the patients that got radiation. The patients that got far lower left radiation to the final implant, about 21% radiation after failed lumpectomy or mastectomy after failed lumpectomy, and then a radiation to the expander. And you can see that these two groups are the ones that I will discuss. They look at PMRT in patients with implant-based reconstruction. So chest wall radiation has become increasingly common following mastectomy. And in my practice currently, I think at least 25 to 30% of the patients that are referred to me will be getting post-mastectomy radiation. But the need for post-op radiation may or may not be known prior to immediate reconstruction. And the dilemma we were faced with, this is back around 2000, was do we leave the tissue expander in place if they're going to get radiation? Do we remove the expanders? Do we convert to a delayed reconstruction? And preoperatively, if we were sure that there would be post-op radiation, do we delay the implant reconstruction? Do we reconstruct with a flap and then radiate the flap? Probably not a great idea either. And then what if the patient is not a flap candidate? So the solution we came up with, and this was a multidisciplinary coordinated approach, which included chemo, implant exchange, radiation. Ultimately, we decided to just proceed with the immediate breast reconstruction with placement of a tissue expander. And then we dealt with all the oncologic treatment in the appropriate fashion. And this was the algorithm that we have followed probably for 2.5 decades. Place the tissue expander at the time of the mastectomy, expand starting about 2 weeks post-op, expand during chemo. And these were mostly patients that got adjuvant chemotherapy. So there is enough time to expand, then to do the exchange about 4 weeks after chemo, and then to start the radiation 4 weeks after the exchange. So they got all their appropriate oncologic treatment at the right time. And what we're essentially doing with this algorithm is radiating the final implant. The other algorithm, which has become much more common now, is radiating the expander. And this is in patients who get neoadjuvant chemotherapy. And at least in my experience, there are more and more patients that get neoadjuvant chemotherapy and fewer with adjuvant. But basically, if they're going down this pathway, by the time I see them, they're already on neoadjuvant chemo. We arrange the mastectomy and placement of the tissue expander about 3 to 4 weeks after completing chemo. We rapidly expand the patient, ideally in 6 weeks. Often it's 3 or 4, sometimes it's up to 8, but we like to start radiation within 8 weeks after placement of the expander. And then I will usually wait 6 months after completion of radiotherapy to allow all the acute changes to improve, and then to do the final implant. So this is the algorithm, radiating the expander. The previous one was radiating the final implant. So these two algorithms have been part of the way we approach these patients for now at least 2.5 decades. Now, the question is, if you have the choice, which algorithm will give you the best outcomes, and how do you go about with the time? How do you time these procedures? When we looked at, if you look at the literature, they're comparing radiating expanders to implants. There are variable outcomes. They're mostly focused on just surgical outcomes and loss of a reconstruction. There's no information on aesthetic results or patient-reported outcomes. So how do we answer the question, what is the optimal timing with good evidence? This is a systematic review that basically concluded that most studies were retrospective. There were small numbers of cases, lack of control groups. So we set out to answer this question, and this has now been 2 decades ago, and published this particular paper looking at what is the optimum timing. And I will share some of the data and information from this particular publication. So with these two algorithms, radiating the expander versus radiating the permanent implant, which I already went through in detail describing the two, we then decided to look at all tissue expander and implant reconstructions over a 10-year period in my practice. And within my practice, my standard follow-up is to see patients once a year, and then to evaluate them post-op and prospectively collect outcomes. The surgical technique for essentially all of these patients is that all tissue expanders undergo total musculofascial coverage. And by that, I mean placement under the pec major, partly under serratus or serratus fascia, and then also rectus fascia. So we get total coverage with vascularized tissue, and I call this total musculofascial coverage. And I think it is essential to minimizing complications, whether you are radiating the expander or radiating the implant. The radiation technique is pretty standard in most of these patients, and it's usually tangential beam in our institution at the time. As I said before, all patients are evaluated at a minimum of 1 year and then on a yearly basis. And I put in surgeon-reported outcomes into the database, and this is my own evaluation of capsular contracture grade, aesthetic results on a 5-point scale, whether the expander is lost, whether the implant was lost, and then was there overall reconstructive failure. And then in addition to the surgeon-reported outcomes, the patients in the past 15 years or so have been filling out the breast-Q. And we accumulate all of that data prospectively. So I'm going to show you what the outcomes were, both with regard to surgeon-reported and patient-reported outcomes. The modified Baker classification system is something that I think most of you are pretty aware of. And a class 1 is usually no contracture, class 2 mildly firm, class 3 moderately firm, and class 4 severe contractures. The breast-Q reconstructive the BreastQ assessment has 5 modules, and I think the 2 most important are satisfaction with breast and satisfaction with outcomes. I'll show you the data on that for all the patients that were followed up. So within this 10-year period, there were about close to 1,800 implant-based reconstruction patients, 1,400 non-radiated, about 100 got radiation to the expander, and about 200 radiation to the final implant. When you look at the unadjusted reconstructive failure rate, you can see that on the left, non-radiated, about 4.6% of patients lose their implant or expander. If you radiate the expander, about 18%, and radiating the implant, 12%. So clearly, if you radiate the tissue expander, you're more likely to lose the overall reconstruction. And although this is what many people look at, just the final unadjusted reconstructive failure rate, I think with our ability to follow these patients out very long term, you can see that a better way is to use a Kaplan-Meier approach. And the green curve on top, you can see about at 6 years plus, 5% of patients lose their implants. Radiation to the permanent implant in blue, about 14-15% lose their implant, and radiation to the expander, about 32%. So clearly, again, radiating the expander, you are much more likely to lose the final reconstruction than radiating the implant. And you have to decide, if you have a choice, which way do you go? And I always have this discussion with patients if there's a choice. When you look at a multivariate analysis and odds ratios, you can see the upper 2 bars, both radiating the implant and radiating the tissue expander increase your odds ratio by 4 or 5 times of losing the reconstruction. So there's no question about that. In looking at capsular contracture rates, on the far left is our non-radiated patients, in the middle, radiation to the expander, on the right, radiation to the final implant. And the darker blue bars are more severe contractures. And you can see for sure that if you radiate the final implant on the far right, you're much more likely to have a grade 3 to 4 capsular contracture than if you radiate the final expander. Not to say that you still don't get some acceptable results in radiating the final implant, because again, 50% are grade 1 or 2, but very definitely your results contracture wise are better with radiating the expander. When we look at aesthetic results, you can see on the left are unilateral reconstructions, bilateral on the right. Bilaterals always give you much better outcomes, but in light blue are the very good to excellent results. And you can see that radiating the expander gives you a slightly better chance of getting the good to excellent result than radiating the final implant. When looking at the BreastQ, you can see in all these categories, satisfaction with breasts, outcomes, physical well-being, sexual well-being, etc. There's really no difference in patient-reported outcomes between radiating the expander and radiating the implant, but certainly in the non-radiated patients, the BreastQ scores are much better. So just to show you some clinical examples of both results and complications, when you radiate the implant, and this is true of the expander too, you'll see the acute changes on the left. And this used to terrify me when patients first came to see me. I then delayed seeing them until 2 months after radiation was completed. And you can see here on the left, on the right photograph, left breast, after 6 months, much, much better. And in many of these patients, you don't even see the discoloration. Here's a patient right after exchange to a permanent implant. Here she is during radiation, and again, a terrifying sight. But if you look at her 6 months later, most of this settles down. And many of these patients, as you see here, can get really very good results. This is at most a grade 2 capsular contracture. Complications. When whether you radiate implants or tissue expanders, you're more likely to end up with an infected implant which has to be removed. You can end up with exposed implants like this. So very definitely complications are higher with radiation. In looking at capsular contractures, I'm just going to show you what I consider a grade 4, 3, 2, 1, grade 4 being the most severe, and they can look, these are some of the worst. And it's very interesting in all these patients, none of them wanted to have their implant removed or replaced with a flap. Most of them have been through so much that they say, you know what, this is better than being flat. So patients' perspectives and wishes are certainly very important. Grade 3 capsular contractures, not as severe, but still you can clearly see the difference between the right and left breast. This one's elevated, it's usually firmer. That's a grade 3 capsular contracture. For most patients, this works very well, and it's for most of them very acceptable. Another grade 3 on the left breast. Grade 2s, visibly, you often can't tell with these patients that they have a contracture. It's just that the implant feels firmer, and these are all grade 2s. In grade 1s, it's very difficult to tell the patients had radiation. They're still soft, they don't have capsular contractures, and it's hard to tell which one's radiated, as you see here. So, at least 50% of patients will end up with a grade 1 or 2, and then another 25-30% with a grade 3. And for most patients, this is perfectly acceptable. And it's still very much worthwhile doing the reconstruction. So to conclude on all the data, the odds of reconstructive failure are clearly higher with radiation to either the tissue expander or the implant compared to non-radiated patients. Radiation to the tissue expander has increased failure rates compared to radiating the final implant, 32 versus 60%. Aesthetic results in capsular contracture rates are slightly better for patients with radiation to the expander as compared to the implant, and patient-reported outcomes do not differ between the two types of radiation. So what's the take-home message? I think the management of PMRT and breast reconstruction is multidisciplinary. It needs to take into account oncologic treatment, surgical options, aesthetic outcomes, and the patient's wishes. And these, since oncologic approaches continuously evolve, as you see over 2 decades, my approach has had to change, and you have to adapt as a plastic or reconstructive surgeon to these changes. And always, obviously, most important that the patient gets the appropriate oncologic treatment. So what should we recommend for patients? I think patients need to be provided with the best information on potential outcomes in order to make an informed decision. And then we go from there. So now to change to a little more subjective information, and these are my observations over 3 decades. Key lessons: radiation is never a good thing, at least for us plastic surgeons, and radiation will almost always have some impact on your result. However, do I still think it's worthwhile? Surely. So what have I learned about radiation breast reconstruction? My thoughts on this subject are subjective, but also based on a large clinical experience with over 5,000 breast reconstruction patients, of which about 1,500, about a third, have received radiation of some form. And then there's another 3,000 non-breast reconstruction patients, those head and neck patients, chest wall, extremities that I also deal with. So that my interaction with radiation and reconstructions is pretty wide. So what about timing of radiation and breast reconstruction? As I showed you, I think the timing of radiation and surgery is important, and it makes a difference. I will usually wait at least 4 weeks after surgery prior to starting radiation. Certainly do not radiate an area that has eschar or is not completely healed. And occasionally this happens, and it's very likely to lead to implant or expander loss. I will usually wait at least 6 months before operating on a patient that has been radiated, and although this is still debated, I think it is much better to wait and to work on the tissues when everything has mostly recovered from acute radiation changes. So definitely wait at least 6 months before radiating, and as I showed you before, things look a lot better 6 months later. Avoid radiating eschars or open wounds like this, because then you'll end up with exposed implants like this. What about outcomes? And this is a generalization, but I think it is actually fairly true. And I don't have good documentation for these numbers, but it's a general impression. If you radiate 100 patients with the same dose and technique, and I think this is true whether it's an implant or whether it's autologous tissue, about 10 to 20% will look perfect afterwards. About 10 to 20% will look terrible. And in between, there's a curve between the two extremes of excellent and very poor. And where any individual patient falls on the curve is very unpredictable. So it's patient dependent, and I let patients know this, and I'll say, look, I still think we should go ahead, but you may be in that very good group or you may be in the very bad group, and neither one of us have any control over it. What are the, as I showed you before, what are the outcomes with implant-based reconstruction, and what are the chances of long-term loss of the final reconstruction? I will tell a patient if we radiate the implant, it's somewhere between a 15 to 20% chance of losing the final reconstruction, and radiating the expander, it's up to 30%. And this is true. That number includes early losses and very late losses. I still have patients that come in 10, 15, 20 years after the reconstruction who've had radiation and they lose their implant for a variety of reasons. And it is certainly much more common than in non-radiated patients. I showed you these curves, but basically radiating the expander, you're more likely to lose the reconstruction than radiating the final implant. So with regard to outcomes after radiation and breast reconstruction, I think radiation will always have some impact on the reconstruction, and it very definitely with implants, but I think also true with flaps. With regard to contractures, the Baker classification system refers specifically to implants. There is no grading system for flaps, but a flap will turn stiff, firm, distorted, and have skin discoloration just as an implant does. And I call this a flap contracture. And I think patients need to be aware that having a flap and radiating it is not avoiding the problem. And when we look at contractures, and again, this is whether it's implants or flaps, and I showed you the data with implants, if you radiate either flaps or implants, approximately 10 to 20% of patients will have no contracture, no tightness, no stiffness of the tissues. About 30% will have a mild contracture, about 40 to 50% will have a moderate contracture, and then usually less than 10% will have a severe contracture. But again, this is unpredictable, and it depends on the patient and how they react to the radiation dose. But it's worthwhile, I think, giving them these approximate numbers with regard to outcomes. Here's a flap contracture. This was a beautiful result, and you can see it's been ruined by radiation, and it's a very stiff, what I would call the equivalent of a grade 4 contracture in an implant. Another flap, you can see this is rock hard, and there was loss of tissue up here, which we can now deal with some fat transfer. But at the end of the day, still, is it worth doing a flap and then radiating it and taking this chance? Radiating implants, as I've shown you, grade 4, 3, 2, and 1, certainly the patient could fall anywhere within any one of these categories. What about radiation technique? So I don't have any good data because I don't have enough numbers, but my impression as we've gone from tangential beam to IMRT to even now proton beam, I see patients with very good results and very good bad results within about the same type of distribution as I described. And I think, again, it's to a large extent, it's patient specific. So I'm not convinced that any of even the much newer modalities are better than the old standard. But I think there is a difference in how radiation is delivered, and it does make a difference in outcomes. I see it within my own institution between radiation oncologists, and I see certainly between my institution and others, outcomes can really vary. So what are the key points that I've learned from breast reconstruction and radiation? Radiation is never a good thing. Timing and technique does make a difference, and radiation will almost always have some impact on your result. Thank you very much.
Thank you, Dr. Cordeiro. Now, Dr. Fabrizio Braselli, please, you can open your... Okay, you can make two questions to the doctor.
Okay. Hi, Peter. Very nice to see you again.
Good to see you again.
Excellent presentation as usual. I would like to ask you two questions. One, you mentioned in your presentation, in your experience, do you think the new techniques of radiotherapy have improved the results? For example, you are not so afraid anymore to have those complications with those IMRT techniques? And
as I said, I'm not convinced that it does make a huge difference, but we don't have the numbers to look at it. I think in concept, some of these techniques minimize injury to the skin and to the soft tissues, et cetera. I'm not sure that it really makes a huge difference. And, proton beam sounded like it would be a great approach. I still see patients with some really terrible results. And this is true not only in the breast, but in the head and neck and in other locations. And I think this is certainly a place where we could do more extensive studies to compare outcomes between the different techniques. But, to some extent, radiation oncologists, and this is true of oncologists, will do with it whatever they think is the best oncologic approach for the patient. And so I never get involved. I'll say whatever the technique is, we'll see how it goes. So as a plastic surgeon, I don't like to dictate one versus the other. And I think ultimately oncologic outcomes will dictate what the best approaches are. And certainly some of these techniques like IMRT and proton beam are better in certain circumstances oncologically.
Perfect. And a second question is when the patient, for example, she has a local recurrence or she's mutated, a BRCA mutated patient, and she had prior radiotherapy, how do you approach the reconstruction? Do you go direct for implant? Do you put an expander? Or do you go for a flap reconstruction?
So this is a patient who's had conservation radiation, and then she comes in and now she needs a mastectomy. Yeah. In these patients, certainly you need to look at them. And if the quality of their skin is horrendous, if they have a variety of scars that are going to really complicate, for example, an implant-based reconstruction, certainly they're not going to get an expander or an implant. But I used to routinely do flaps on patients who were previously radiated. And I started to veer away from that. I used to do in patients who couldn't get an abdominal flap, buttock flap. I used to do a latissimus with an expander or an implant. And over time, I ended up moving towards using just the latissimus muscle. And the result at the end of the day, whether you just expand the patient or put in a latissimus, makes very little difference. And I think you can still very safely expand patients who are radiated. It takes a little more effort. You need to release a lot more a muscle, contracture, et cetera, but you can get very good results. So I don't think it necessarily requires a flap, but you need to assess the patient, talk to them, see what they want. And I think for patients who are not flap candidates and who don't want flaps, you can still use an expander, an implant. And I found actually that in that group, the surgical outcomes, both with regard to implant loss and aesthetic contractures, et cetera, is much better than the PMRT patients. Because I think it's often a long time since radiation, which helps a little bit. And if you expand them right away, you're not dealing with permanently scarred radiated tissues. You can still expand them and then go from there.
Perfect. Fantastic, Peter. Nice to see you. And thank you for the Karina, Dario, Faranti for invitation.
Thank you all.
Thank you.
Have a good Saturday.
Thanks.
Good Saturday, and we will try to continue and to finish for the day. Thank you very much. And Cari, if you want to share.
Es el doctor Alberto Rancati, que es director de cirugía oncoplástica de la Universidad de Buenos Aires, profesor asociado de la Universidad de California en San Diego, y el moderador va a ser el doctor Marcelo Irigo. Dejo de compartir y doy lugar al doctor Rancati.
Gracias, Karina. Buenos días.
Buenos días.
Gracias, Darío,
Bienvenido.
Gabriel. Muchas gracias por la invitación. Un placer verlo a Fabrizio y a Peter. Voy a compartir pantalla. Vamos a hablar entonces sobre el uso de fluorescencia en cirugía oncoplástica mamaria. Todos sabemos que últimamente la cantidad de publicaciones que podemos encontrar en PubMed sobre fluorescencia entre 1995 y el 2021-2023 fue una ascendencia así feroz, y cada vez más estamos utilizando la fluorescencia. ¿Qué es la fluorescencia? Es el uso de verde-indocianina, que es un compuesto que se une a una proteína plasmática que ya estuvo aprobado y en uso en 1957. Y lo que permite, así como lo hicieron cuando la aprobaron, hacer una parangiografía, los oftalmólogos de vasos de la retina, el verde-indocianina se une a una proteína plasmática y nos permite hacer una angiografía en tiempo real de los tejidos, para ver la perfusión de los tejidos. ¿Qué necesitamos para hacer fluorescencia en una cirugía? Bueno, una torre, como hay varias empresas que tienen ya disponibilidad del equipamiento, Stryker, Olympus, Diagnostic Green, que es el verde-indocianina que utilizamos, y una cámara, que es una endo o una exocámara, que a través de esta pantalla, de este monitor, nos permite visualizar los vasos sanguíneos y la perfusión de los tejidos. Cuando empezamos a utilizar la cirugía con fluorescencia, empezamos a ver vasos y ver coloración de los tejidos, que va del verde brillante al negro, y de acuerdo a eso evaluábamos la vitalidad. Todavía podíamos al principio saber qué color de gris en el medio nos permitía conservar un tejido que estaba mal perfundido, y eso era un problema, y no identificábamos los vasos. ¿Por qué les digo esto? Porque es importante para utilizar la fluorescencia conocer la anatomía vascular, porque si uno no conoce la anatomía vascular, difícilmente pueda sacarle provecho a las imágenes que ve. Y como dice el aforismo, el que no sabe lo que busca no entiende lo que encuentra. Entonces, si uno no sabe qué estamos buscando y por dónde viene la vascularización de la mama, es muy difícil saber si lo que estamos observando es útil o no, ya sea para la perfusión o para el tallado de un colgajo. Entonces, bajo una luz con una longitud de onda cercana a la infrarroja, una cámara nos permite en la pantalla ver la perfusión de los tejidos. Acá vemos, por ejemplo, una evaluación preoperatoria de una paciente ideal, mama chica, una paciente joven, en donde le vamos a hacer una mastectomía y vemos entonces la mamografía, la cobertura grasa, la glándula, y después de ponerle verde-indocianina, empezamos a ver estas imágenes vasculares, que si entendemos, ahí arriba vemos la mamaria, acá la segunda intercostal, vemos la mama desde arriba, empiezan a aparecer los vasos desde abajo, la cuarta intercostal, y acá vemos entonces los perforantes, la ICAP, ICAP, MyCap, que es los perforantes de la quinta intercostal, y de acuerdo a eso uno puede dibujar sobre la mama los perforantes, como si fuera una geografía digital en tiempo real, y evitar entonces seccionarlos. En una mama como esta chica es sencillo porque la mama no se moviliza tanto en la posición de decúbito dorsal como cuando uno está operando una mama grande, en donde los vasos se mueven. Entonces, la ventaja sobre lo que es hacer un ecodoppler de los vasos perforantes, que en donde uno en el ecodoppler se orienta muy bien con el origen del vaso perforante, pero a veces el transcurso del perforante en el tejido mamario con el peso de la mama se moviliza. En cambio, con el verde, indocianina, uno puede dibujar exactamente. De esa manera podemos preservar, acá vemos el lateral intercostal artery perforator, el anterior intercostal, que está siempre en hora 6 en el surco mamario, y entonces movilizamos la incisión, acá, como ven, para hacer una nipple sparing mastectomy, más sobre el surco mamario lateral, preservando entonces de esta manera el ICAP, que hoy sabemos que es un vaso muy importante para la perfusión del complejo areola-pezón. Esta es una animación que presentamos ahora en este último libro del doctor Mauricio Nava, en donde vemos la anatomía vascular de la mama. Entonces vemos que de la arteria mamaria interna, que es rama de la arteria subclavia, viene la perforante, la segunda intercostal, que es una arteria muy importante que corre pegado al colgajo en la grasa entre la piel y la glándula, y va a irrigar el complejo areola-pezón. Y como vemos siempre es extramamario, o sea, el disco mamario no involucra el origen de la segunda intercostal. En cambio, la tercera y la cuarta sí están dentro del disco mamario y uno en la mastectomía tiene que sacrificarlos. Entonces, uno empieza ya a tomar entonces, a unir conceptos vasculares con técnica quirúrgica y saber que uno no tiene que sobredisecar los colgajos para no lesionar el origen de la segunda intercostal, porque es innecesario, porque oncológicamente no significa mejor tratamiento y sí más compromiso de la vitalidad del complejo areola-pezón. Esto es importante no solamente en las mastectomías conservadoras, sino también en la cirugía conservadora de la mama, en las cuadrantectomías, en donde uno tiene que decidir qué pedículo va a preservar para la vitalidad del complejo. Y entonces, cómo va a ser la resección parcial de la mama, preservando la vitalidad del complejo. Lo que sabemos hoy es que la nipple sparing mastectomy, las mastectomías conservadoras, se convirtieron en el standard of care en el tratamiento del cáncer de mama, y esto no aumentó el índice de recidivas. Lo que sí aumentó es el índice de complicaciones isquémicas. ¿Por qué? Justamente por la lesión vascular y la antigua creencia de que la mama tenía una circulación random y que de alguna manera le iba a llegar sangre al complejo areola-pezón. No hay otra manera que es a través de los vasos perforantes. Estos vasos perforantes, acá como vemos la cuarta intercostal que está dentro del disco y la quinta, que estaba mal descripta, y se decía que corría por la fascia de Boehringer, también rama de la arteria mamaria interna, corre en el surco mamario y da estas ramas, ICAP, Anterior Intercostal Artery Perforator, la Middle Intercostal Artery Perforator, que llegan corriendo por el tejido subcutáneo en el polo inferior de la mama. Sobre el borde axilar de la mama, rama de la arteria axilar y en un 20% rama de la subclavia, tenemos la arteria perforante torácica lateral. Esta arteria torácica lateral, también muy potente y que corre por el tejido celular subcutáneo, nos permite darle vascularización al complejo si uno sabe dónde está y puede preservarla. Entonces, el concepto de uso de fluorescencia es poder elegir el pedículo, como vemos acá, en donde tenemos un pedículo superior, estamos hablando de un pedículo de la segunda intercostal, o sea, hay que empezar a cambiar la clasificación topográfica de superior, medial, superomedial, inferior o central a el nombre de la arteria que le da vascularización. Entonces sabemos que esta es la segunda intercostal, sabemos que esta es la cuarta intercostal, sabemos que esta es la torácica lateral, sabemos que el pedículo inferior, descrito por Leslie Ribeiro, es el pedículo del ICAP, Anterior Intercostal Artery Perforator. Muy importante y hago hincapié porque es un pedículo neurovascular. Tiene un nervio que da sensibilidad al complejo. Entonces, si podemos preservar el ICAP, podemos mantener también la sensibilidad de la mama después de una nipple sparing mastectomy. Y en cirugía conservadora, vemos que la resección tumoral, en general, es opuesta a la selección del pedículo. Si tenemos un tumor en el cuadrante inferior, vamos a pensar en un pedículo superior. Si tenemos un tumor en el cuadrante superior, vamos a pensar en un pedículo inferior. O sea, siempre opuesto a la vascularización. Entonces, acá vemos, después de una reconstrucción con implante, cómo está preservada la segunda intercostal, con cual tenemos la certeza de que no va a tener compromiso vascular el complejo, porque no violamos el origen de la segunda intercostal. ¿Por qué es importante esto? Porque después de una mastectomía, la vascularización del complejo areola-pezón en la nipple sparing mastectomy va a ser de la segunda intercostal, la tercera y la cuarta se sacrifican, va a quedar la quinta, que corre por el surco mamario y la grasa del polo inferior, y la torácica lateral. Y no hay más. Esos son los vasos. Entonces, en una gran disección, en un colgajo muy fino, y en donde uno llega hasta la clavícula en la disección y sobrepasa el surco mamario, no le ofrece más garantía oncológica al paciente y sí más complicaciones isquémicas. De esta manera, con estas imágenes, en donde podemos verlas en blanco y negro o podemos verlas en color, tenemos la posibilidad de tener un control postoperatorio y un planeamiento, lo que se llama mapping preoperatorio de los vasos perforantes. Otro caso donde vemos también cómo llega sangre dominante en un 60% en las mamas es la arteria perforante segunda intercostal, o sea, muy importante no violar el disco mamario, la distancia en donde termina el disco mamario para hacer la mastectomía, porque no es necesario, porque embriológicamente estos vasos perforantes corren el tejido celular subcutáneo entre la piel y la glándula. Entonces, hacer un colgajo muy fino lo que da es mayor riesgo de complicación vascular y no mayor seguridad oncológica. Esto nos permite en pacientes como estos, donde vemos que tienen una cicatriz en el polo superior, acá podemos pensar que la segunda intercostal está comprometida, porque no va a llegar vascularización al complejo porque tenemos una incisión previa. Entonces, sabemos dónde está la segunda intercostal, tercera y cuarta hay que sacrificarlas. Es muy importante en estos pacientes, entonces, este vaso perforante, Anterior Intercostal Artery Perforator, el Medial Intercostal Artery Perforator y varias arterias de la epigástrica superficial que están en la porción superior interna de la región torácico-abdominal. Entonces, decidimos mover en todas estas pacientes de nipple sparing mastectomy con mamas chicas o medianas a una incisión lateral del surco mamario, 7 centímetros de incisión, en donde sabemos que cortamos el LICAP, el lateral intercostal, pero preservamos el ICAP y el MICAP porque sabemos que la segunda va a estar comprometida y tenemos entonces también la torácica lateral que nos va a dar vascularización, no la segunda. Y acá vemos la reconstrucción posoperatoria, en donde tenemos buena vascularización, buena vitalidad, ninguna complicación isquémica. Y esa es la incisión lateral y siempre ponemos un drenaje para que no haya seromas. ¿Qué pasa con la reconstrucción autóloga en los pacientes que podemos reconstruir que no quieren implantes, por ejemplo? Bueno, existe la posibilidad, hoy gracias también a la fluorescencia, de identificar estos pedículos perforantes, como vimos recién. Podemos chequearlos por por ecodoppler, y tenemos la posibilidad de realizar esto que es un colgajo ICAP lateral, en donde uno toma toda esta grasa hasta la axila y la rota y reemplaza el volumen mamario o en una explantación el volumen del implante por tejido autólogo. Este es un caso de una paciente que había tenido ya cuadrantectomía, radioterapia, contractura capsular, dolor, quería sacarse los implantes y completar la mastectomía contralateral. Entonces tallamos este colgajo, ven que es una paleta de 20 centímetros por 7 y tiene un espesor de más o menos 2 centímetros, supongamos. Entonces 2 por 7, 14, 140, por 2, 280. Tenemos un volumen de 280 centímetros cúbicos con este colgajo para hacer la explantación y colocar el colgajo. Llega hasta la línea axilar posterior, con lo cual no se ve en la espalda esta incisión hasta donde llega la disección del colgajo. Y este es entonces un colgajo ICAP modificado. Al principio lo hacíamos lateral llegando a la espalda, ahora lo modificamos hacia la axila. Y entonces acá vemos... Suena bien, suena bien. Perdón, acá vemos el colgajo, el volumen que tenemos para rellenar el espacio, el bolsillo de la prótesis. Acá vemos los dos, porque le completamos la mastectomía del lado izquierdo también, y la vascularización de este colgajo. Todo por una sola arteria, que es la arteria intercostal anterior, en hora 6 en el surco mamario. Acá vemos entonces cómo podemos visualizar la vitalidad. Esto blanco que se ve es el uso del verde indocianina. Todo esto significa que está vital el colgajo y podemos hacer la reconstrucción sin problema. Entonces nos ayuda no solamente a ver la vascularización del complejo, sino también a ver la vascularización del colgajo. Y si uno sabe entonces dónde está el origen de esa arteria, es muy fácil disecar este colgajo, que es un colgajo, como ven, dermograso, y aparte le podemos poner grasa, hacer un lipofilling para aumentar el volumen. Y queda con una incisión solamente en la axila, no modificándose mucho la anatomía ni ningún compromiso estético posterior. ¿Por qué es importante esto? Porque estas tres arterias, que son el LICAP, el ICAP y el MICAP, lateral intercostal, anterior intercostal y middle intercostal, son los que en estas mamas, que ya son mamas más voluminosas, nos van a permitir hacer este colgajo dermograso inferior y podemos de esta manera preservar el complejo areola-pezón pegado a la dermis para hacer la reconstrucción sin necesidad de injertarlo y haciendo una resección de reducción cutánea. Acá vemos entonces el colgajo, porque sabemos hoy que lo importante es la preservación de estas arterias intercostales, estos perforantes, y podemos también controlar, ahí ven las arterias, y podemos tener una evaluación en el momento de la luminosidad también de los vasos. Acá vemos entonces cómo a través de esas tres perforantes tenemos la posibilidad de tallar un colgajo seguro que va a envolver la prótesis. Podemos hacer una reconstrucción prepectoral o retropectoral, pero con el polo inferior cubierto con este colgajo dermograso de seguridad. Hicimos 23 disecciones cadavéricas para ver estos vasos perforantes, reproduciendo una skin reducing mastectomy en un cadáver, y este es el ICAP. Esta arteria que llega hasta el complejo areola-pezón, que sale, estamos viendo el surco mamario desde adentro, desde cefálico, este es el surco mamario. Acá vemos entonces el ICAP, muy importante porque es el que nos da no solamente vascularización, sino sensibilidad. Tiene un nervio este pedículo, es un pedículo neurovascular que nos da la posibilidad de, con este solo pedículo, mantener sensibilidad del complejo, como sucede en las reducciones mamarias a pedículo inferior. Entonces, por eso es importante no utilizar la incisión submamaria central y empezar a utilizar una incisión submamaria lateral para preservar estos vasos. No hay que ponerse cómodo quirúrgicamente y cortar todo el surco mamario porque estamos cortando toda la vascularización inferior. Se pensaba antes, Boehringer había descrito que este vaso corría por la fascia de Boehringer junto con la cuarta intercostal. Hicimos una corrección a este concepto y publicamos por dónde corre esta arteria, que en realidad corre pegada al tejido celular subcutáneo. Por eso es importante no tallar innecesariamente colgajos tan finos, porque la vitalidad y la sensibilidad dependen de estos vasos y pedículos perforantes. Y acá vemos el caso real, en donde podemos conservar el complejo areola-pezón en una skin reducing mastectomy, con reconstrucción con implante inmediata, sin tener ninguna lesión isquémica del colgajo y del complejo areola-pezón. ¿Podemos identificar pacientes de riesgo en nipple sparing mastectomy? Sí, sabemos hoy que, y por eso empezamos a investigar la vascularización, después de complicaciones personales como estas, extrusión, isquemia, necrosis. O sea, decíamos, ¿por qué en un paciente sale bien, en un paciente sale mal esta cirugía? ¿Por qué tenemos isquemia o necrosis y este patrón de isquemia con los expansores en la zona irradiada? Bueno, es siempre un tema vascular y de la perfusión de los tejidos. Para hacer la reconstrucción se pueden utilizar este tipo de colgajos utilizando justamente el ICAP, el TDAP, el ICAP, depende cómo uno quiera movilizar el tejido. Acá tenemos la imagen real para hacer un salvataje de un expansor. Vemos cómo podemos tallar un colgajo y identificar el vaso perforante. Entonces ahí tenemos la certeza de que estamos preservando el vaso. Miren el perforante, y eso nos permite movilizar el tejido con total seguridad en la disección. De esta manera estamos transfiriendo un tejido autólogo vascularizado que nos permite hacer este tipo de reconstrucciones con resección de toda la zona dañada y cobertura y reconstrucción inmediata en un tiempo con implante, transfiriendo ese colgajo LICAP. Entonces, ¿cuál es el concepto importante que nos da hoy la posibilidad, la fluorescencia? De establecer un mapeo. O sea, todos los cirujanos que se dedican a diferentes especialidades conocen la vascularización del órgano que van a operar. Ningún cirujano gastroenterológico operaría un estómago sin saber la vascularización. Ningún cirujano de cabeza y cuello operaría una tiroides sin saber la vascularización. Los cirujanos de mama operamos mamas sin saber la vascularización. Y no es tan difícil. O sea, son estos y se repiten en todos los pacientes. Siempre son estos vasos perforantes los que van a irrigar el complejo areola-pezón. Y si no tenemos el concepto y no incorporamos el concepto de cortar innecesariamente perforantes, no vamos a disminuir nuestra tasa de complicaciones. O sea, el concepto es hacer un mapeo prequirúrgico y un control postquirúrgico. Eso lo podemos hacer con verdindocianina. ¿Por qué es importante de vuelta este concepto que hablamos de la cobertura de la glándula mamaria? Porque embriológicamente los vasos perforantes corren en el tejido celular subcutáneo entre la piel y la glándula. Antes de que se desarrolle la glándula mamaria en la mujer o en los hombres, no están expandidos estos vasos. Cuando crece la glándula en la mujer, bueno, desplaza y otros quedan involucrados, como cualquier tumor. Bueno, la mama hay que considerarla como un tumor que crece en la mama, benigno, que es una glándula con una función, involucra algunos vasos perforantes, como la tercera y la cuarta intercostal, y algunos están afuera. Y acá la vemos. O sea, si vemos con atención en la resonancia magnética o en la mamografía digital, vamos a poder ver los vasos perforantes. Y entonces sabemos que tenemos que preservarlos. Miren cómo acá la segunda intercostal corre pegado a la piel, y podemos tener una complicación si hacemos un colgajo fino innecesario, porque sacar esta grasa no nos da ningún beneficio oncológico. Entonces, los pacientes tipo 1 con poca cobertura grasa, y eso lo podemos saber antes de la operación, son pacientes difíciles para reconstruir. Y esto lo podemos chequear también con el verde indocianina. ¿Por qué? Porque los vasos siempre transcurren en este espacio, tengamos mucha grasa o poca grasa. Estos pacientes son pacientes riesgosos. Los pacientes tipo 1 de cobertura son pacientes que o por daño térmico con el electrobisturí, o por disección con la tijera y sección de los perforantes, o por sobredisección de los colgajos, podemos disminuir la vascularización del complejo. Entonces estos son pacientes para hacer reconstrucción en 2 tiempos, para hacer reconstrucción retropectoral, para poner una malla. Le vamos a tener que hacer fat grafting. En cambio, estos son pacientes que si hacemos una buena mastectomía, que oncológicamente es lo correcto, por eso no es que alguien deja los colgajos finos o alguien deja los colgajos gruesos. O sea, hay una sola manera de hacer la mastectomía, que es hacerla bien, que es sacar la glándula preservando la grasa, por el resultado cosmético y porque la vascularización, los vasos perforantes corren en ese espacio. Entonces, sabemos de vuelta, el disco mamario lo dibujamos presionando la mama, marcamos la incisión inframamaria lateral y por ecodoppler o por verde indocianina hacemos el mapeo de los perforantes. De esta manera sabemos qué vasos vamos a respetar y qué vasos vamos a seccionar, porque es imposible, como la tercera y la cuarta, que están dentro del disco mamario. Entonces, en un corte sagital tenemos la segunda, la tercera, la cuarta, la quinta, que hoy sabemos que corre por el surco mamario y el polo inferior, no por con la cuarta, como estaba descrito por Huang en su artículo en 1960, y larga una conexión entre la cuarta y la quinta. Y cuando hacemos la mastectomía, ¿qué nos queda? La segunda, la quinta y la torácica lateral. De eso va a depender la vascularización del complejo. Entonces, ya no es más cuestión de suerte, sino es un desconocimiento vascular. Entonces, de esta manera tenemos el mapping, podemos planear una incisión en S itálica en el cuadrante supraexterno o submamaria lateral para hacer la mastectomía en mamas pequeñas o medianas, y la vascularización del complejo va a estar completamente indemne si dejamos al menos 2 pedículos de todos estos que hay. ¿Para qué nos sirve también el verde indocianina y la fluorescencia? En pacientes que vamos a operar, ya sea por ejemplo en este caso, que ya tiene una reducción mamaria previa a pedículo incierto, no sabemos si fue un pedículo inferior o un pedículo superior, o pacientes que le hicieron múltiples biopsias, bueno, si hacemos preoperatorio un verde indocianina, vemos como en este caso cómo marca la segunda intercostal, con lo cual esta paciente había tenido una reducción mamaria a pedículo superior. Podemos hacer una amputación de todo este pedículo inferior y no vamos a tener ningún problema. Ahora, si hubiera tenido un pedículo inferior, hubiéramos estado en problemas si hubiéramos tenido una necrosis del complejo. Eso antes no lo podíamos saber, era una cuestión de apostar a que hubieran pasado más de 10 años. Hoy podemos saber exactamente cuál es la vascularización del complejo. También lo podemos usar en ganglio centinela, la fluorescencia. Como saben ustedes, la fluorescencia, el verde indocianina, ponemos en el frasquito, en el vial, 10 centímetros cúbicos de verde indocianina, hacemos 3 abones periareolares de 1 centímetro. Para hacer el ganglio centinela hay que hacerlo antes de hacer la perfusión de los tejidos, si no nos da una mancha sobre la mama, porque si no se hace endovenoso, el anestesista le pone 2 centímetros endovenosos de esta misma concentración, o sea, un frasquito, 10 de solución fisiológica, tomamos 1 primero, hacemos el ganglio centinela, nos vamos a lavar, ven que esto es antes de empezar la cirugía, hay que esperar por lo menos 15 o 20 minutos, y vemos entonces cómo migra en los linfáticos el verde indocianina hasta ubicar el ganglio centinela. Y ahí hacemos directamente la incisión. Esta es una paciente que tenía ya, como ven, una reducción mamaria previa, con lo cual era un caso más difícil de identificar, pero bueno, uno de esta manera puede hacer una disección mucho más minuciosa y atraumática. ¿Qué es lo nuevo que hay en fluorescencia? Bueno, esta cámara, que se llama Dendrite Camera, que es una cámara que por fluorescencia, pero no con luz infrarroja, como estuvimos viendo hasta recién, sino con luz ultravioleta, hace que los nervios sean fluorescentes. De esta manera, ya hay muchas publicaciones en cabeza y cuello, en cirugía mamaria, ahora en axila. El doctor Nicola Rocco de Nápoles acaba de publicar un último artículo sobre la disección axilar con la cámara, en donde uno puede preservar todos los nervios y la vieja consideración que uno le dice al paciente sobre que cuando uno hace una disección axilar es normal que tenga dormida la cara interna del brazo. No, no es normal. O sea, es una lesión de una rama del toracobraquial. Ahora, si uno la puede ver, puede evitar la lesión y evita el daño térmico. Esta cámara permite eso, permite ver autofluorescencia de los nervios sin colocar ningún compuesto, o sea, solamente con un juego de luces y filtros. Entonces, acá vemos una disección del ICAP, que les decía, el quinto intercostal anterior, en hora 6. Acá ven una disección abajo con luz de quirófano y arriba con la cámara. Entonces ven como al lado de los vasos hay un nervio. Bueno, ese nervio es un nervio sensitivo que es muy importante en la sensibilidad del complejo areola-pezón. Y esto también es fluorescencia. Acá vemos un paciente en donde preservamos la vascularización y preservamos los nervios.
Ahí,
y vemos
sí.
la sensibilidad
Ahí.
Conservada. La sensibilidad conservada del complejo areola-pezón, lo cual esto va a cambiar y sí va a ser una mastectomía conservadora, no solamente conservadora de piel y de complejo, sino también de la sensibilidad. Entonces, esta nueva modalidad, creo que tenemos que incorporarla, es la posibilidad de conocer la anatomía y de esa manera tener la posibilidad de preservar la vitalidad de los tejidos y la sensibilidad de los complejos areolares. Como último comentario, creo que hace muchos años que estamos haciendo lo mismo en cirugía mamaria. Es tiempo de avanzar. Tenemos tecnología hoy disponible. Estamos entrando en una etapa quirúrgica de decisión basadas en imágenes. No es más la experiencia. O sea, la experiencia es importante, pero sin tecnología no podemos avanzar. Por lo cual, esta etapa nueva, si ustedes piensan, todo lo que tenemos disponible en imágenes va a cambiar la cirugía mamaria. Toda esta tecnología ya demostró ser segura y efectiva. Tenemos, por supuesto, que desarrollar algoritmos basados en evidencia, y en eso estamos trabajando, y tenemos que avanzar sobre la adopción de la tecnología. Lo más difícil es que uno quiera cambiar lo que está haciendo para incorporar algo nuevo. Y si no damos ese paso, vamos a seguir cometiendo los mismos errores. Muchas gracias.
Muchas gracias, Alberto. Damos paso al doctor Marcelo Irigo. Por cuestión de tiempo, solamente, Marcelo, disponemos de una pregunta.
Gracias. Muchas gracias, Karina. Gracias, Gabriel, por la invitación. Felicitarte, Alberto, por el trabajo que has realizado. Realmente es un cambio de paradigma en la preservación de estructuras fundamentales para la calidad de la reconstrucción de mama. Simplemente una pregunta que tiene que ver con dos aristas. Una, la curva de aprendizaje, y ¿cuál considerás que son las contraindicaciones, diría, absolutas? Porque a la luz de tu presentación no vislumbro qué tipo de contraindicación puede llegar a haber.
Gracias. Sí, yo te diría que no hay contraindicaciones, o sea, no hay complicaciones, no vimos nunca ninguna reacción alérgica, hace la cirugía más entretenida, hace comprender qué es lo que estamos haciendo, te evitas malas sorpresas y al revés, te llevas buenos resultados impensados. creo que la posibilidad hoy de cambiar es no solamente el uso de la tecnología, sino incorporar el conocimiento vascular de la mama. Creo que si uno incorpora el conocimiento vascular y la anatomía, tenemos que volver a la anatomía. O sea, estuvimos haciendo distintos tipos de mastectomías sin pensar en la anatomía. Y hoy, gracias a las imágenes, tenemos la posibilidad de repensar lo que estamos haciendo. Es solamente eso, repensar cómo podemos optimizar los resultados para nuestros pacientes.
Muchísimas gracias. Karina, lo dejo a tu disposición. Sí. Gracias.
Muchísimas gracias, muchas gracias. Darío, continuamos con las presentaciones.
Sí, gracias Alberto, realmente muy novedosa la presentación, pero bueno, por tiempo tenemos que continuar. Vamos a ver si podemos presentar finalmente la clase de Giuseppe. Si entra, la vamos a tratar de pasar, así que Alex, la puedes compartir. Y ahí con esto estaríamos finalizando. Perdón a todos por el problema que hubo desde el punto de vista informático, o sea, de poder pasar, pero bueno, estas cosas en los Zoom pasan y bueno, no podíamos poner audio a la presentación. Alex, ¿querés compartir la pantalla? A ver si lo podemos terminar, así cumplimos con todos, o si no, ya lo dejaríamos para la semana próxima, que lo agregaríamos.
Darío, le volvemos a recordar, mientras le damos tiempo a Alex que comparta, que vamos a sortear libros, ebooks, signos en imágenes mamarias y los libros del Instituto Europeo de Oncología. Han compartido en el chat. Si por favor lo pueden volver a compartir para quienes no se han inscrito quieran participar del sorteo. Deben tener la participación en los 2 sábados y el último vamos a realizar el sorteo. Bueno, vemos que
Cari.
continuamos con la dificultad técnica. Bueno, si les parece, nos encontramos el sábado próximo.
¿Quieres compartir vos la pantalla, Cari? Así terminamos. En el paso también de sí, donde los que quieren, que ahí me mandaron un par de WhatsApp para ver dónde pueden comprar tu libro, en tu ebook.
Sí. Mi ebook lo pueden comprar en mi página web, que es www.doctoracarinapesce.com.ar.
Ok, perfecto. Bueno, y a todos, muchísimas gracias. Muchísimas gracias a todos.